Good morning, everyone, and welcome. It's 7 a.m. on the West Coast and 10 a.m. on the East Coast. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is June 17th, 2022, and I'm pleased to call today's ACIP meeting to order. First, I will turn it over to Dr. Melinda Wharton to start with today's announcements.
Good morning, and thank you, Dr. Lee. Could I have the next slide, please? Good morning, and welcome to the June 17th and 18th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all time unless you're called on or until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the virtual hand-raising function in Zoom to let her know you want to speak. And during the discussion period, she'll take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just please don't stream live video. Although we'll ask ACIP voting members to turn on their video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we'll be holding one oral public comment period today at approximately 2:15 p.m. Eastern Daylight Time. To create a fairer and more efficient process for requesting to make an oral comment, we ask that people interested in making an oral comment submit a request online in advance of the meeting. Priority is given to those advanced requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0079. Information on the written public comment process, including as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but those members are prohibited from participating in a committee's votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide, please. We are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the committee. Detailed instructions for submission of names of potential candidates to serve as ACIP members are now available on the ACIP website. The deadline for applications for ACIP membership has been extended to August 15th, 2022 for the 4-year term beginning July 2023. We will be filling 6 positions at that time, including a consumer representative position. Next slide. And with that, I will return the podium back over to Dr. Lee. Thank you.
Thank you very much, Dr. Wharton. And I do want to emphasize that the ACIP nominations are open, and I would ask members of the audience if they would be interested in considering this position. It's really important service to our country, and I really appreciate those who are both willing to be considered and many of those who are on the committee today who have been willing to serve. So for the ACIP members, I will ask that you state your name, your affiliation, and whether you have any conflicts of interest for today's roll call. And today we will start with Dr. Covet.
Good morning. I am Kip Talbot. I'm an associate professor of medicine and health policy at Vanderbilt University Medical Center. I'm an adult infectious disease doctor and have no conflicts. Thank you.
Thank you, Dr. Talbot. Dr. Sanchez.
Hi, good morning. I'm Pablo Sanchez. I'm a professor of pediatrics at the Ohio State University College of Medicine and a neonatologist and pediatric infectious disease specialist at Nationwide Children's in Columbus. Thank you. And I have no conflict.
Thank you, Dr. Sanchez. Dr. Paling.
Good morning. This is Kathy Paling. I am a professor of pediatrics, epidemiology, and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist, and I have no conflicts. Thank you.
Thank you, Dr. Paling. Ms. McNally.
Good morning. Veronica McNally with the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you, Ms. McNally. Dr. Long.
Good morning. This is Sarah Long. I'm a professor of pediatrics at Drexel University College of Medicine and a pediatric infectious disease doctor in Philadelphia, and I have no conflict of interest.
Thank you, Dr. Long. Dr. Lair.
My name is Dr. Jamie Lair. I'm the owner of a private family practice in Ithaca, New York, and I have no conflicts of interest.
Thank you, Dr. Lair. Dr. Daly.
Good morning. Matt Daly here. I'm a senior investigator at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts of interest. Thanks.
Thanks, Dr. Daly. Dr. Chen.
Good morning. Wilbur Chen, professor of medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I have no conflicts.
Thank you, Dr. Chen. Dr. Brooks.
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation in South Los Angeles, and I have no conflicts. Good morning.
Morning, and thank you, Dr. Brooks. Dr. Bell.
Beth Bell, clinical professor in the Department of Global Health in the School of Public Health at the University of Washington in Seattle, and I have no conflicts.
Thank you, Dr. Bell. Ms. Bata.
Good morning, Lynn Bata. I'm a public health nurse working as a clinical consultant for the immunization program at the Minnesota Department of Health, and I have no conflict.
Thank you, Ms. Bata. And this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine, Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health, and I have no conflicts. So we do have quorum today, and we can proceed. For our ex officio and liaison members, I will announce the organization name, and please indicate if you are present and your first and last name. First, we'll begin with Centers for Disease Control and Prevention. Dr. Posner, are you still muted?
Dr. Romero.
Thank you. Sorry about that. Jose Romero, present.
Welcome, Dr. Romero, and we will introduce Dr. Romero in a little bit. Centers for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance for CMS.
Thank you. Food and Drug Administration.
Good morning. Doran Fink, present on behalf of the U.S. Food and Drug Administration, Office of Vaccine.
Thank you. Health Resources and Services Administration.
This is Mary Rubin from the Division of Injury Compensation Programs, HRSA.
Thank you. Indian Health Service.
Good morning. This is Dr. Matthew Clark representing the Indian Health Service.
Thank you. National Institutes of Health.
Good morning. John Bible from the National Institute of Allergy and Infectious Diseases.
Good morning. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. David Ken with OIDP National Vaccine Program. Thank you.
Thank you. I will run through our liaison representatives next. I will skip a few that I know are not able to be on for roll call this morning. And at the end, I will ask if they have been able to join, if they would like to state their names. So please don't worry if I skip over your organization briefly. American Academy of Family Physicians.
Good morning, Pamela Rockwell, Professor of Family Medicine, University of Michigan, liaison for the American Academy of Family Physicians.
Thank you. American Academy of Pediatrics.
Maldonado, Professor of Global Health and Infectious Diseases, Stanford University, and representing the Committee on Infectious Diseases, American Academy of Pediatrics.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, editor of the AAP Red Book.
Thank you. American College Health Association. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. American Geriatric Society.
Ken Schmader for AGS.
Thank you. America's Health Insurance Plans.
Bob Gluckman here.
Thank you. American Immunization Registry Association.
Elizabeth Perella here.
Thank you. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Oh, thank you, Dr. Freihofer. We'll go back to American Nurses Association.
Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Good morning, Stan Garog, present.
Good morning. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean and Professor at the Loma Linda University School of Pharmacy, Professor of Preventive Medicine at Loma Linda University School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, representing AIDS.
Thank you. Association for Prevention, Teaching, and Research.
Rick Zimmerman, University of Pittsburgh, present.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Lee. This is Niraj Shah, the Director of the State of Maine CDC and the President of ASTA.
Good morning. Biotechnology Innovation Organization. Council of State and Territorial Epidemiologists.
Good morning. This is Paul Cieslak, Oregon Health Authority Medical Director for Communicable Disease and Immunizations, representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Shelley Beeks, the chair of NACI.
Good morning. Infectious Diseases Society of America. International Society for Travel Medicine.
Good morning, Elizabeth Barnett, representing ISTM.
Good morning. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield, representing NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Good morning, this is Bill Schaffner, Medical Director of the NFID.
Morning, thank you. National Medical Association.
Good morning, this is Dial Hewlett, representing the NMA.
Thank you. Pediatric Infectious Diseases Society.
Good morning, this is Mark Sawyer. I'm substituting for Sean O'Leary and representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine. Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Thank you, Dr. Dries. And with that, I will ask if there are any liaison members who've been able to join after a roll call and would like to announce themselves.
Dr. Lee, it's Jason Goldman, Affiliate Associate Professor at the Florida Atlantic University, General Internal Medicine, Coral Springs, Florida, representing the American College of Physicians. Pleasure to be here.
Thank you, Dr. Goldman. Anyone else?
Good morning, Dr. Lee. This is Matt Zahn. I'm on representing NACHA.
Oh, thank you, Dr. Zahn. Any additional liaison members would like to announce themselves? All right, thank you, everyone. Now, I am very excited to take a pause and introduce and welcome back our colleague, Dr. Jose Romero, who has just started in his role as the director of the National Center for Immunization and Respiratory Diseases for the Centers for Disease Control and Prevention. As many of you remember, prior to becoming center director, he served as the Arkansas Secretary of Health and director of the Arkansas Department of Health. He led his state's response to the COVID-19 pandemic from 2020 to 2022. And before that, he was the chief medical officer for the Arkansas Department of Health and director of PEDS-ID at the University of Arkansas for Medical Science. Importantly, many of you remember that Dr. Romero served as our chair, so chair of the Advisory Committee on Immunization Practices, and he saw us through the start of the COVID-19 pandemic until October 2021 when his term ended. We are so grateful that he's now willing to serve our country yet again as director of NCIRD, which is a critically important role for our country, and particularly during this pandemic and many other infectious diseases that seem to be rising in our country. We are thrilled that you're here today, and we wanted to give you a moment to say a few words, Dr. Romero.
Thank you, Dr. Lee. And with your permission, I'll put myself on video as I address the committee. So good morning to you all. Most of you I have met, and I'm sorry I have not met all of you because of the pandemic. I hope that I can do so in the future. I'm pleased to be joining you all as the Advisory Committee on Immunization Practices convenes today and tomorrow to consider expanding COVID-19 vaccines to children ages 6 months up to 5 years. I want to thank the ACIP voting members, its liaisons, the ex officio members, and the CDC members for the countless numbers of hours you have all dedicated to questions of COVID-19 vaccines, as well as non-COVID vaccines over the last 2 years. You have been asked to give so much of yourselves, your time away from your family, your own weekends and holidays during this unprecedented period in our history. And I'd be remiss if I didn't thank Dr. Posner for sitting in this position prior to my arrival. He's done a heroic effort in maintaining our communications with you all. I also would like to thank everyone at the CDC and all our public health partners who have worked hard to get ready the vaccines that will be for children and for families should the results of your deliberations be favorable for their use. Lastly, I would like to convey my gratitude to the public who have come to speak with the ACIP during our public comment sessions. It is important that we hear all points of view. It was less than a year ago that I sat where many of you are now as chair of this ACIP committee. Many things have changed since then, in some ways that we did not expect. I certainly did not anticipate that I would return to speak to the ACIP as the newly appointed director of the Centers for CDC's National Center for Immunization and Respiratory Diseases, NCIRD. I'm humbled and grateful to be here with all of you now, and I'm excited for the progress that we have made and the promise of the availability of additional vaccines for everyone to protect themselves and their families from the most serious and deadly consequences of SARS-CoV-2 infection. I very much look forward to continuing collaboration with all of you on the work to fight SARS-CoV-2 pandemic, along with our intensified efforts to refocus attention on immunization across the lifespan, with things like catching up on gaps in childhood immunization coverage, addressing adult immunization inequities, and preparing for the upcoming influenza season. Thank you all for all you have done, all you will do in the future, and all you are doing now. I look forward to seeing many of you at the next Thursday when I am able to join you for the regularly scheduled ACIP meeting. Back to you, Dr. Lee, and thank you for this opportunity to address the committee, its members, liaisons, and the public.
Thank you so much, Dr. Romero, and we are so happy to have you back. Next, I'll ask Dr. Melinda Wharton to say a few words to set the stage for today.
Thank you, Dr. Lee. First, I'd like to invite our colleagues from FDA to provide an update on recent regulatory action by the Food and Drug Administration. Dr. Marks or Dr. Fink?
Dr. Fink.
Yeah, hi, it's Dr. Fink. Dr. Marks is otherwise occupied this morning, but I will give my usual update. And so I think as many of you are aware, a short time ago, earlier this morning, FDA took action to authorize the Moderna COVID-19 vaccine for use in pediatric age groups 6 months through 17 years, and also took action to authorize the Pfizer COVID-19 vaccine for use in the pediatric age group of 6 months through 4 years. Both of these actions followed our VRBPAC, Vaccines and Related Biological Products Advisory Committee meetings earlier this week. The primary basis of effectiveness for both of these vaccines in the age groups for which they've just been authorized was an immunobridging analysis, or rather immunobridging analyses comparing neutralizing antibody responses among children enrolled in clinical trials to those in individuals in adult or older adolescent age groups for whom the vaccines had been demonstrated to be effective in efficacy trials. Additionally, we had other supportive information on effectiveness that added to the immunobridging assessment. The FDA assessment of safety data was that the safety profile of both of these vaccines in pediatric age individuals from clinical trial experience, as well as available safety information from post-authorization use in older individuals, supported determination of favorable benefit risk, and therefore FDA determined that the known and potential benefits of these vaccines when used in individuals in the age ranges for whom they are authorized outweigh the known and potential risks, and therefore the vaccines are now available in all age groups from 6 months upwards under emergency use authorization. I do want to reiterate a sentiment that was conveyed at the VRBPAC meetings earlier this week, that authorization of these vaccines down to age 6 months represents an important step in our efforts to combat the COVID-19 pandemic, and it provides options to parents and caregivers of children who wish to use the vaccines to improve their protection against COVID-19 and its serious outcomes. So with that, I'll turn it back over to you, Dr. Wharton. Thank you.
Thank you very much. So the Advisory Committee on Immunization Practices is meeting today to begin discussions on the use of COVID-19 vaccines in younger children. We will be discussing Moderna's COVID-19 vaccine as a 2-dose series for children 6 months to 5 years of age, and Pfizer's COVID-19 vaccine as a 3-dose series for children 6 months to 4 years of age, and plan to ask for a committee vote tomorrow on these 2 questions. We'll be discussing use of the Moderna vaccine in older children, those 6 to 17 years of age, at our regularly scheduled meeting next week on June 23rd. With that, I'll turn the meeting back over to Dr. Lee. Thank you.
Thank you, Dr. Fink and Dr. Wharton. We will move on to our first session of the morning. Dr. Matt Daly, chair of the COVID-19 Vaccines Work Group, will provide an introduction and an overview of today's session. So Dr. Daly, the floor is yours.
Thank you so much, Dr. Lee. I'll just wait a minute for slides to be pulled up. Okay, thanks so much. So I'm speaking today on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. This slide illustrates trends in the number of COVID-19 cases in the United States across all age groups. And since the start of the pandemic, There have been over 85 million reported cases, and currently in the country, we're averaging more than 103,000 reported cases per day. Next slide, please. And then illustrated on this slide are the number of COVID-19 deaths in the United States across all ages. And since the start of the pandemic, more than 1 million individuals have died from COVID-19. And currently, almost 300 people are dying each day from COVID-19 in the country. Next slide, please. To orient you to the figure on the right, age in years is on the x-axis and COVID-19 deaths per 100,000 population is on the y-axis. And as you can see, children at every age have died from COVID-19. And to put these deaths in a broader context, COVID-19 is the leading cause of death among infectious diseases for people aged 0 to 19 years. And COVID-19 is the 7th most common of all causes of death for people ages 0 to 19 years. And among people ages 1 to 4 years of age, COVID-19 is the 5th most common of all causes of death. Next slide, please. This figure shows rates of COVID-19 deaths by vaccination status among all people 5 years of age and older. And the rate among unvaccinated is the black line, and the rate among vaccinated with at least a primary series is the blue line. And through March of 2022, unvaccinated people 5 years of age and older had 10 times the risk of dying from COVID-19 compared to those vaccinated with at least the primary series. And phrased another way, these data and this figure provide real-world evidence that most deaths from COVID-19 are preventable through vaccination. Next slide, please. So we've included this slide to provide some additional context for today's discussion. Each of the diseases listed are vaccine preventable. And please note that the age groups may differ depending on the vaccine. I'd draw your attention to the last row in this table, which shows the average number of deaths per year in the time prior to when these vaccines were routinely recommended for use. And COVID-19 has caused more deaths than all of these other diseases. And today we're here to meet about prevention of COVID-19. And with the exception of COVID-19, for all the diseases in this table, as a nation, we've achieved relatively high vaccination coverage. And this means that parents and providers have accepted that the benefits strongly outweigh the risks and that it is worth vaccinating, even though the number of deaths are relatively rare, because these deaths are preventable through vaccination. Next slide, please. On this slide and the next, we wanted to describe influenza vaccination and disease. And we do so while recognizing that there are some differences between seasonal influenza and pandemic COVID-19, but we thought this might provide some additional context for the discussion today. So over the last decade, between 63% and 75% of parents of children 6 months through 4 years of age chose to vaccinate their children against influenza. Next slide, please. And so starting on the right of this slide, influenza causes substantial disease burden in young children every year. And vaccine efficacy is variable, ranging from 19% to 60% over the past decade, with some of this variability in vaccine efficacy due to changes in the circulating influenza strains. And despite this variable vaccine efficacy, most parents vaccinate, and a substantial amount of disease is averted. So now I'll direct you to the left side. In this age range, approximately 4.3 to 20.1 million illnesses have been prevented through vaccination over the past decade through vaccination. So 2.9 to 15.5 million healthcare visits have been prevented. Between 32,000 and 164,000 hospitalizations have been prevented, and between 130 and 2,350 deaths have been prevented through vaccination in children 6 months through 4 years of age. Next slide, please. Currently, there's no COVID-19 vaccine that is authorized for use and recommended for use under age 5, although we heard from Dr. Fink that now that vaccines are authorized in this age group. And as Dr. Fink has said, now there is another vaccine that's authorized, and we'll discuss that next week as well. Next slide, please. So the FDA update Dr. Fink provided, and just to provide a little bit of additional context, on June 14th, VRBPAC met to review the request for an emergency use authorization for Moderna in children and adolescents 6 through 17 years of age. We'll discuss that next week. On June 15th, VRBPAC met and reviewed a request for an emergency use authorization for the Moderna vaccine in children 6 months through 5 years of age, and the Pfizer vaccine for use in children 6 months through 4 years of age, and those were authorized this morning, and that's the topic of discussion today and tomorrow. Next slide, please. So I just want to highlight COVID-19 vaccine workgroup activities in the last 3 to 4 weeks. So the work group reviewed and discussed the vaccine safety, immunogenicity, and efficacy data, including both the immunobridging and laboratory confirmed direct efficacy for Moderna's vaccine from 6 months through 5 years of age and from 6 to 17 years of age. We also, in the last several weeks, reviewed vaccine safety, immunogenicity, and efficacy data, again, including both immunobridging and laboratory confirmed efficacy for the Pfizer vaccine for use in children and 6 months to 4 years of age. In addition, we reviewed COVID-19 epidemiology and outcomes for children 6 months through 5 years of age. We also reviewed the post-authorization vaccine effectiveness for COVID-19 vaccines in children and adolescents aged 5 through 17 years. And then we reviewed the grading of recommendations, assessment, and evaluation, or GRADE, and the evidence to recommendations framework for both vaccines for use in children 6 months through 5 years of age. Next slide, please. So here is the agenda for today. First, we're going to hear from Dr. Fleming Dutra from the CDC, who's going to review epidemiology of COVID-19 in young children. Then we'll hear from Dr. Link Gellis from the CDC, who's going to review COVID-19 vaccine effectiveness in children and adolescents. Following that, we'll have a break. Following the break, we'll hear from Dr. Das from Moderna, who will present safety and immunogenicity of Moderna's 2-dose primary series in children ages 6 months through 5 years of age. Following this, we'll hear from Dr. Gruber from Pfizer, who will review safety and immunogenicity of BNT162b2 as a 3-dose primary series in children 6 months through 4 years of age. Following this, we'll hear from Dr. Oliver from the CDC, who will review mRNA COVID-19 vaccines in young children. She will provide a summary as well as workgroup interpretation. After Dr. Oliver's presentation, we will hear public comment and then close for the day. Next slide, please. So I want to sincerely thank all of the workgroup members for the ACIP COVID-19 vaccines workgroup, including ACIP members, ex officio and government members, liaisons, consultants, and CDC leads, Dr. Sarah Oliver and Dr. Evelyn Twentyman. Next slide, please. I'd also like to thank all of the CDC participants who made all of this work possible. Next slide, please. Looks like that's my last slide. So back to you, Dr. Lee. Thank you very much.
Thank you so much, Dr. Daly. And I just want to confirm that, I see. Okay. Just a brief announcement that typically the slides will get posted in addition on the ACIP website simultaneously with the presentations. And I believe there's a request to make sure that those are posted for the public. We will work on that at the same time. Thank you, Dr. Daly, for that introduction and for that updated information. It's really helpful to place this in context. Next, we would like to introduce Dr. Catherine Fleming Dutra, who will present on the updated epidemiology of COVID-19 in young children.
Good morning. Can you hear me?
Yes, we can.
Thanks. Next slide. So here's an overview of what I'll cover today. Next slide. Of course, we're talking today about the epidemiology of COVID-19 in children ages 6 months through 4 years. But for purposes of comparison, I will also show data from children ages 5 through 11 years and adolescents 12 through 17 years who have already been eligible for COVID-19 vaccination for some time. Next slide. So let's start with COVID-19 incidence and burden. Next slide. So here we see the trends in the number of COVID-19 cases in the U.S. among persons of all ages, and you just saw this, this graph. As of June 14th, there were more than 85 million total recorded cases of COVID-19 in the U.S. Next. And the Omicron surge started in December 2021 and led to a large spike in COVID-19 cases through the winter of 2022. Next. And as of June 14th, as we just heard, the 7-day moving average was more than 100,000 cases per day. Next slide. So now focusing on the pediatric population, here we see the weekly rate of COVID-19 cases per 100,000 population by age group. COVID-19 case rates were much higher during the Omicron surge compared to any previous time during the pandemic, with the highest rate seen in adolescents 12 through 17 years, shown in dark blue, then older children 5 through 11 years, shown in light blue, and followed by infants less than 1, shown in gray, and children 1 through 4 years, shown in red. Next slide. Total during the pandemic, over 570,000 COVID-19 cases have occurred in infants aged less than 1 year, and over 1.9 million cases have occurred in children ages 1 through 4 years. Next. But not all COVID-19 cases are captured using traditional disease surveillance methods, because some cases are asymptomatic, not diagnosed, or not reported. Tracking the proportion of the population with SARS-CoV-2 antibodies, or the seroprevalence, can improve understanding of population-level incidence of COVID-19. This figure shows the seroprevalence of infection-induced SARS-CoV-2 antibodies from the National Commercial Lab Seroprevalence Study from September 2021 through April 2022 by age group. Seroprevalence in all age groups increased substantially during the Omicron surge. And as you can see, children ages 6 months through 4 years in red had a larger increase in seroprevalence since December 2021 than the other 2 age groups. The study is now continuing with 2-month data collection periods, and the rate of rise in seroprevalence was less steep between February 2022 than the combined March-April time point, when the seroprevalence was estimated at 71% among children ages 6 months through 4 years. Next. Moving on to healthcare associated with COVID-19, starting with emergency department or ED visits. Next. Here is the weekly percent of ED visits with a COVID-19 diagnosis among all ED visits for children ages 1 through 17 years from CDC's National Syndromic Surveillance Program through May 2022. The dashed line marks December 19, 2021, the first date when more than 50% of nationally sequenced SARS-CoV-2 specimens were the Omicron variant, which was followed by a surge in COVID-19 ED visits among children ages 1 through 4 years, 5 through 11, and adolescents 12 through 17. Although a few slides ago, we saw that the rate of COVID-19 cases was lower among children ages 1 through 4 versus older children and adolescents, here you can see during the Omicron surge, here you can see that the trends of COVID-19 ED visits during the Omicron surge were very similar among all 3 age groups. Next slide. Moving on to COVID-19 associated hospitalizations, including burden and severity. Next. Here we see COVID-19 associated hospitalizations per 100,000 population from CDC's COVID-19 surveillance system. Hospitalization rates also increased during the Omicron surge to the highest rates yet seen during the pandemic. During 2022, among these age groups, hospitalization rates were highest among children ages 6 months through 4 years, shown in red, followed by adolescents 12 through 17 in dark blue and children 5 through 11 in light blue. Next slide. To further illustrate this point, we can look at the cumulative COVID-19 associated hospitalization rates. You can see that during the Omicron surge among children 6 months through 4 years, the slope of the cumulative hospitalization rate was steeper than among older children and adolescents. And by March 2022, the cumulative hospitalization rate was higher among children 6 months through 4 years who were not eligible for vaccination during this time than among adolescents who were. Next slide. And we know that vaccination prevents hospitalization. Here are the monthly COVID-19 associated hospitalization rates by vaccination status. Adolescents 12 through 17 years in dark blue who were vaccinated with at least a primary series shown by the solid line had lower hospitalization rates than those who were unvaccinated in the dashed line. Although children ages 5 through 11 years in light blue have lower hospitalization rates overall than adolescents, the same pattern can be seen after they became eligible for vaccination in late 2021. It's important to note that the benefits of vaccination are more pronounced when the disease burden is high, and we can predict that with future COVID-19 surges, the unvaccinated will continue to bear the burden of disease. Next slide. Next slide. So why are these children being hospitalized? The COVID-19 surveillance platform captures hospitalized persons with a positive SARS-CoV-2 test within 14 days of or during hospital admission. And here we see the proportion of children ages 6 months through 4 years in COVID-19 who were primarily admitted for COVID-19 during the Omicron period and the pre-Omicron period. Primarily admitted for COVID-19 was defined based on the reason for admission field on the case report form. So if the chief complaint or the history of present illness in the medical chart documented fever or respiratory illness, COVID-19-like illness, or suspicion for COVID-19, then that case was categorized as having COVID-19 as the primary reason for admission. Examples of non-COVID-19 reasons for admission are trauma or inpatient surgeries. So in both the Omicron and pre-Omicron periods, you can see that the vast majority, 86 to 87%, of children ages 6 months through 4 years with COVID-19 associated hospitalizations in COVID-19 were primarily admitted for COVID-19. Next slide. So who's getting hospitalized for COVID-19? This figure shows the percent of children ages 6 months through 4 years with COVID-19 associated hospitalization with at least one underlying health condition from 2 CDC surveillance platforms, COVIDnet, and the new vaccine surveillance network. In both surveillance systems, just under half of children ages 6 months through 4 years with COVID-19 associated hospitalization had one or more underlying health condition. Conversely, this means that over half of children ages 6 months through 4 years had no underlying health condition. Next slide. So now let's look at markers of severity among COVID-19 associated hospitalization by age group in COVIDnet, focusing on December 19th, 2021 through March 31st, 2022, or the Omicron period. Children ages 6 months through 4 years, again shown in red, were more often admitted to the intensive care unit or ICU than older children and adolescents. During this time, almost 24% of children ages 6 months through 4 years were admitted to the ICU. Children ages 6 months through 4 years were more often placed on high-flow nasal cannula than older children and adolescents. And over 6% of children ages 6 months through 4 years were placed on mechanical ventilation, versus about 5% of children 5 through 11 years and 4.5% of adolescents. These data indicate that during Omicron predominance, COVID-19 associated hospitalization severity among children 6 months through 4 years appeared to be as high or higher than that in older children and in adolescents. Next slide. Now that we've examined the burden and severity of COVID-19 associated hospitalization among pediatric age groups, let's pivot and compare COVID-19 hospitalization in children to other key pediatric infectious diseases. Next slide. And we'll start by comparing hospitalizations for influenza and COVID-19. This figure is from a recent paper which used data from COVIDnet and FluServeNet, which conducts surveillance for influenza-associated hospitalizations from October 1st to April 30th each year, the typical U.S. influenza season. The solid black line is the COVID-19 associated hospitalization rate during October 2020 through September 2021, and the solid red line is the preliminary COVID-19 associated hospitalization rate during October 21 through April 22. Influenza-associated hospitalization rates from 2017 through 2022 are shown by flu season in gray and in the dashed red line for the preliminary data from the most recent flu season. Next. Among children 6 months through 4 years, COVID-19 hospitalization rates from October 2020 through September 2021 were lower than influenza hospitalization rates during pre-pandemic influenza season. However, in this age group, the preliminary COVID-19 hospitalization rates during October 2021 to April 2022, which includes the Omicron surge, were as high or higher than influenza hospitalization rates for all influenza seasons shown here. And as we all know, influenza vaccination is recommended every flu season for all children 6 months of age and older. Slide. COVID-19 associated hospitalization burden among children 6 months through 4 years was similar to or exceeded the pre-vaccine era burden of other now vaccine preventable diseases, including hepatitis A, varicella, and vaccine type invasive pneumococcal disease. Next slide. And tragically, COVID-19 is a leading cause of mortality in children. Next slide. This figure shows the number of COVID-19 deaths in children by age through May 11, 2022. And sadly, among children ages 6 months through 4 years, there have been 202 COVID-19 related deaths, accounting for 1.7% of all deaths in this age group. Next slide. And COVID-19 was a leading cause of death among children and adolescents during the pandemic. Previously, we've shown data to ACIP that during 2020, COVID-19 was the 11th cause of death among children ages 5 through 11 years. But this has changed through the course of the pandemic. And looking at data through April 2022, COVID-19 now ranks as the 4th and 5th causes of death among children 0 through 19 years of age. Next slide. COVID-19 associated deaths among children ages 6 months through 4 years, as we've already heard today, exceed the pre-vaccine era burden of other now vaccine preventable diseases shown here. Slide. Multi-system inflammatory syndrome in children, or MISC, is another important complication of COVID-19 in children. Next slide. MISC is a severe illness in persons ages 0 through 20 years, characterized by fever, multi-system organ involvement, inflammation, and SARS-CoV-2 infection with no alternative plausible diagnosis. It occurs 2 to 6 weeks after acute infection, and 60 to 70% of patients are admitted to intensive care, and 1 to 2% die. Next slide. Here are the daily MISC and COVID-19 cases reported to CDC. In total, during the pandemic, more than 8,500 MISC cases and 69 deaths have occurred. Reports of MISC, shown by the blue line, typically follow increases in COVID-19 cases, which are shown by the dashed black line. However, following the Omicron surge, reports of MISC did not increase to the same level as occurred following prior waves of COVID-19 cases. Next slide. Now we can look at the weekly MISC case counts by age group through May 31st. Children 6 months through 4 years are shown in dark blue, 5 through 11 in orange, and adolescents 12 through 17 in the middle shade gray blue. Next. And during the pandemic, a total of 1,990 cases of MISC and 9 deaths from MISC have occurred among children ages 6 months through 4 years. Next slide. And unfortunately, throughout the pandemic, MISC has disproportionately affected Black children, which is shown here with the percent of MISC patients ages 6 months through 17 years during the pandemic by race and ethnicity and age group. Next. So let's talk about post-COVID conditions. Next. Post-COVID conditions include a range of new, returning, or ongoing health problems occurring 4 or more weeks after acute SARS-CoV-2 infection, and they occur both in adults and children. A large study in Denmark indicated that children ages 0 through 5 years with SARS-CoV-2 infection are more likely than controls who had no known SARS-CoV-2 infection to experience fatigue, loss of taste, and loss of smell lasting more than 4 weeks after acute infection. Next slide. However, evidence regarding the prevalence and spectrum of post-COVID conditions among children, especially young children, is limited by the inability of younger children to verbalize symptoms, few studies that include children, and among the studies that do, a lack of appropriate control groups, and because symptoms frequently occur in children without known SARS-CoV-2 infection, which makes it difficult to determine which symptoms are attributable to post-COVID conditions. Next slide. And there are other impacts of the pandemic on children and families. Next. And childcare has been particularly challenging for families during the pandemic. This Kaiser Family Foundation graph shows the percent of parents during July and August 2021 who said that in the past year, they or another adult in their household left a job or changed work schedules to take care of their children. Next. And these data highlight the disparities of this impact. Parents of children under the age of 5, younger parents, Black and Hispanic parents, and parents with lower household incomes were more likely to report that their household had a job disruption due to childcare needs. And job disruptions have negative impacts on both parents and children. Next. And other impacts of the pandemic on children include worsening of mental or emotional health, widening of existing education gaps, decreased physical activity and increased body mass index, decreased healthcare utilization and routine immunization, and increase in adverse childhood experiences. Next. So in conclusion, next. To date, COVID-19 has caused more than 570,000 cases among infants less than 1 year and more than 1.9 million cases among children ages 1 through 4 years. The Omicron surge in the United States has led to the highest numbers of COVID-19 cases, emergency department visits, and hospitalization rates among this age group yet seen during the pandemic. Next. Children ages 6 months through 4 years are at risk of severe illness from COVID-19. More than half of hospitalized children ages 6 months through 4 years had no underlying condition. During Omicron predominance, COVID-19 associated hospitalizations among children ages 6 months through 4 years had similar or increased severity compared to older children and adolescents. And the burden of COVID-19 hospitalization is similar to or exceeds that of other pediatric vaccine preventable diseases. And finally, the COVID-19 pandemic continues to have significant impact on families and increases disparities. Next. Presentation is the work of many people that I would like to thank. And next. Thank you.
Thank you very much for that excellent presentation. This presentation is now open for questions. Ms. Bata?
Yes, and thank you, Dr. Fleming, Dutra. Just a clarification about the data related to hospitalization during Omicron and deaths. We saw that rise. Was that a proportional rise compared to the other variants in the original Wuhan strain, or was there something special about the Omicron variant that created more hospitalizations?
Just to clarify, are you referring to just the overall rates of hospitalization, the rise in overall rates of hospitalization?
Yes.
I think that's it's an important and interesting question, and I'll start, and if there's others on the line who want to weigh in. I think we see very clearly with the epidemiology throughout the pandemic, or from the case count, the ED visits, and the hospitalization rates, that we saw a tremendous surge in all of those COVID-19 cases, COVID-19 ED visits, and hospitalizations during the Omicron surge. So it certainly reflects the overall epidemiology of the pandemic, that there was lots of transmission and infections occurring in the population. I think regarding differences with the variant itself, certainly that is at play with, yes, sir. Oh, I see there's others raising their hands for question. Certainly that's at play with the how much transmission and infection there was occurring in the country. I don't know if Dr. Havers is on the line, if she wants to speak a little bit more, if she wants to add anything else to that answer, or others too.
Yeah, this is Fiona Havers. Can you hear me?
You can, thank you.
Yeah, no, I think during Omicron, I think there was a very real increase, a massive surge, particularly in young children in terms of severe illness. Probably proportionally, it may have been less severe in general in the population overall, but there was so much community transmission going on at the time that if, a large number of children are being infected, even if most of them don't end up in the hospital, in terms of absolute numbers, we did see a very severe impact on very young children. And it was very striking during the Omicron surge. So I don't know if that directly answers the question, but I think it was a very real increase in that time, particularly among young children. It was very disproportionate among young children, as as Dr. Fleming-Dutra showed.
Thank you. Dr. Paling.
Hi, thank you very much for a fabulous presentation. I would like to highlight a few things to verify that I'm interpreting information correctly and then ask a question. So as I'm looking at this data, I understand that for each age group of children, COVID-19 is either the fourth or fifth leading cause of death, saying that this is not a minor illness in children. And that of the children that get hospitalized, about a quarter will go into the ICU, further verifying it. And humbling enough, half of the children that get hospitalized do not have underlying conditions. So it's not that easy to predict. And that 87% of all hospitalizations are clearly COVID related. So I very much appreciate this data. I also understood that it looks like on the graph that COVID-19 ED visits in the more recent wave are similar or maybe slightly higher than other age groups in children, and that they're clearly higher for COVID hospitalizations than other age groups. One of the things that, now it's the question. So in MISC, we saw that the Blacks were most significantly impacted by the MISC. And so I wanted to ask about, do we have any data about race and ethnicity differences among hospitalizations or ED visits or deaths by race and ethnicity? Thank you.
Thank you for that question. And just to confirm that your interpretation of those highlights was correct. Regarding information about race and ethnicity for hospitalizations, we do have that. And I may just see if Dr. Havers would like to weigh in on that question as well, because much of the data comes from COVIDnet.
Yeah, thank you. We do see large disparities in the COVIDnet data by race and ethnicity. I think a large number of children are disproportionately non-Hispanic, Black, Hispanic, and American Indian and Alaska Native. This has been consistent throughout the pandemic, and it does reflect the disparities we've seen in all age groups, but it is particularly pointed in the pediatric age group as well as adults. But there are disparities on that, and there is data on that publicly available on COVID, on the COVID data tracker as well.
Thank you, Dr. Lair.
Thank you for your presentation. Could you go to slide 30 for me? I wanted to sort of check my math and make sure I'm doing something correctly. If I'm looking at this correctly, for the whole pandemic, we have 8,500 MISC cases. However, when I did the math for the number of COVID cases for children, there's about 15 million. And so what I'm doing, it looks like the order of magnitude is 1 every 2,000 cases of COVID, you have an MISC case. And I just wanted to make sure that that's accurate from the data that I'm seeing, and I'm going to explain why.
Is Dr. Zambrano on the line? We have our MISC unit on the line.
Hi, yes, this is Dr. Zambrano. Can you hear me?
Yes, you can.
Okay, great. Yeah, so there are a few data sources that have actually interrogated this question. And one thing that's important to note is that even among most MISC cases actually are derived from symptomatic or subclinical SARS-CoV-2 infections. And so sometimes looking at it at the COVID-19 cases as the denominator may actually wind up overestimating your incidence. And so we do have some estimates based off of some of our burden and severity models that really have pinned true incidence between about, like, say, 3,000 and 4,000 MISC cases for every SARS-CoV-2 infection, including asymptomatic infection. And so we are actually in the process of updating that data right now, but I'd also be happy to share some resources that provide that estimate as well.
The reason I'm asking is because I have regular questions from parents about what's the risk of my child getting MISC. and they're talking whether it's 1% or 5% or 10%. And my perspective here from this data is suggesting that it's very low, that it's 1 in 2,000 of COVID cases that we know, and that's not even including cases that we don't know. So that's just interesting information for me. Thank you.
Thank you. Dr. Daly?
Yeah, thanks so much. First a comment and then a question. The comment is just, that I so appreciate your ability to put this in some context and framing. And I'm thinking about it for us as members, but also for parents, because parents have long heard the message that, COVID is less severe than in young kids than in older adults. But I feel like your presentation did such a wonderful job of putting it in context of some other things that parents may be aware of, other diseases, other causes of death. So I feel like it's just so important to put it in context in those terms that parents then can sort of use to help with their decision making, because they're asking, is this vaccine needed? And I feel like your talk goes a long way to make the argument that it is. And then my question is it true that for any given hospitalization, that hospitalization may be as severe or more severe for kids under 5 as for other kids of older ages? Thank you.
Yes, thank you for that comment and the question. So if I could have slide 19 again, and I will also ask Dr. Havers to weigh in if she wants to add to this. These data are from the Omicron period, and we COVID-19 did look at markers of severity in that time frame. So ICU, high flow nasal cannula, BiPAP or CPAP use of mechanical ventilation. And these data indicate that at least during this Omicron predominant period from December to March, that it appears that children 6 months to 4 years had, were as likely or more likely really to have these markers of severity. That being said, this is limited to the Omicron period, and this is a time frame in which children ages 5 through 11 and adolescents 12 through 17 were already eligible for vaccination. Dr. Havers, do you want to add to that?
Sure, thank you for that question. I think we are seeing that conditional on hospitalization, a high proportion of kids of all ages have severe outcomes as measured by ICU admission and the use of mechanical ventilation or higher levels of oxygen. But as you can see that, and this is including during the Omicron period, and we published a number of reports about this. So I think it's overall, it's hard to compare severity across age groups, but I do think that, as you can see from these data, that children under 5 years have a high level of fairly severe outcomes. So thank you.
Yeah, I mean, this is Matt Daly again. Just to add to that, I mean, I think as a clinician, being moved to the ICU, we always feel like is a sentinel event, because that acknowledges that this illness is life-threatening, and that's why somebody's being moved to the ICU. So that seems like a reasonable proxy for severity of illness, and this is a high proportion. So thank you.
Thank you. Dr. Long?
Yes, I wonder if we could see the slide about the morbidity and mortality averted by vaccination in the older age groups that you showed us. And I'm so grateful for your putting this together, because these very clear data should just decimate the myth that this infection is not life-threatening in this age group. So thank you for that. And I don't want to take anything away from that, but my question is going to be, what might we expect for this vaccination to do to outpatient and ED visits? So it's that slide that you showed us about things averted in the older age groups.
So I believe you may be either talking about slide 23, which is regarding hospitalization, or slide 27 regarding deaths. Maybe we'll start, may I have slide 23?
Well, my question really was, on those slides, I was so impressed and wanting to get very clear the deaths and hospitalization. I missed, maybe you didn't show us any prevention of outpatient visits or ED visits in the older age group for which we have a lot of data post-vaccination authorization and recommendations? Maybe you didn't show us. That's my question.
I did not have a similar slide for ED visits or cases. I believe that next we'll be hearing a talk from Dr. Link Ellis on vaccine effectiveness, and somewhat different, but may give you a little bit more information on those.
Thank you. Thank you so much, and thank you for this information. Thanks very much.
Thank you. I do have one other question. This is Grace Lee. It's around this question that people keep asking, which is it a difference in the variants in terms of the clinical presentation of kids, or is it related to background rates of vaccination that is protecting a large proportion of kids? And I ask this specifically for MISC, the difference that you see with the number of cases in the Omicron wave and the number of reported cases of MISC seems somewhat different than in prior waves. But on the other hand, I'm just wondering if now with the 5 to 11-year-old age group and the 12 and older having higher rates of vaccination in the background, if that would be expected, or if you think this truly is related to Omicron versus Delta versus other variants.
May I have slide 30 again? And I'm actually going to defer that question to Dr. Zambrano, our MIS expert.
Okay, sure. Thank you. Thank you so much, Catherine. So this definitely is an interesting trend, and it is starting to bear out in multiple data sources that we have seen. And so we are seeing reduced incidence of MISC after Omicron. We can't really at this point tease out whether or not this is potentially attributed to the actual variant, or if this is some conglomeration of, say, immune tolerance built up through either multiple infections or through immunization. But it is a real trend that we are observing.
Thank you. It'd be great if there were ways to untangle this. I'm not sure if the data sources we have available in public health surveillance would provide that, but I do think it keeps coming up.
Oh, I absolutely agree. And we are working to disentangle that very question right now.
Perfect. Thank you so much. Dr. Finley.
Okay, I've got two questions. First of all, when we're talking, one of the things that's been humbling about COVID-19 is it's forever changing. And we've been talking about Omicron, and I wanted to give you an opportunity to talk about, is Omicron one thing, or has that been evolving too? First. I'll stop there and let you answer that question, then I've got a second question.
Absolutely. Omicron is, as we all know, it's a variant of SARS-CoV-2, but there are sublineages within that. And I wonder if we have either Dr. Thornburg or Dr. Scobie on the line who might want to talk a little bit more about Omicron variant.
Yeah, this is Natalie Thornburg. Can you hear me? Okay, great. Yeah, so my audio is a little off. Could you go ahead and repeat the question, please?
Yes. All right. So one of the things that we have recognized is that COVID-19 is forever humbling. And we've been talking about the Omicron epidemic, but is that constant, or how much has that been changing?
Yeah, I mean, the Omicron variants, there are, a lot of different subvariants. And really the first wave that occurred in December, January has been really the most dramatic wave of Omicron. There have been several different subvariants that have sort of changed in prevalence since December. It started with something called BA.1, then BA.2 during the very sort of low time in March and April, and now we're seeing some subvariants of BA.2 and BA.4 and 5 increase. They're all, though, Omicrons that have been circulating, and they do seem to differ a little bit from each other in escape from immunity, but it's subtle differences. They're all Omicrons, but they do not seem to differ in regards to severity dramatically from one another. So it's still really an Omicron wave that we're seeing, but there are subtle differences in the subvariants as they sort of increase and decrease in prevalence.
Okay, thank you. That's very helpful. My second question is related to the slide that's on here, and I very much appreciate Dr. Lair's math. And what I understood was if you take into account asymptomatic disease, about 1 in 3,000 to 1 in 4,000 children will get MIS-C. And if I understand correctly, that 60 to 70% of children with MIS-C will be admitted to the ICU, that means your risk of ICU hospitalization is somewhere around 1 in 5,000 to 1 in 7,000. And I just wanted to see if that math is making sense to others. Thank you.
I'll let Dr. Zambrano weigh in specifically about MIS-C, but I do want to just frame that that is not the only reason that children with COVID-19 are admitted to the ICU. That, as we saw earlier with the COVIDnet data from COVID-19 associated hospitalizations, about just less than a quarter of children in this age group with COVID-19 associated hospitalization are admitted to the ICU. So that math does not take into account hospitalization for acute COVID infection. And Dr. Zambrano, do you want to? I'm sorry.
Thank you.
Add any more to that?
That's very
this is Laura Zambrano. Just to add, I completely agree with you, Catherine. So that Dr. Feeling, that math does add up. I mean, in terms of the overall risk per se of ICU admission attributed to MIS-C, it would probably be in the realm of about, say, 1 in 5,000, 1 in 7,000 infections, including asymptomatic or subclinical infections. But ICU admission attributable to severe COVID is another question entirely, and it is more common. But it is true that about between 60 and 70% of children with MIS-C would be expected to be admitted to the ICU. So it is a very severe clinical complication.
Thank you. I apologize, I have 2 more questions. Today I have a bunch of questions for you. Well, one is a comment in that I think that similar to or akin to MIS-C, we talk about, COVID being less severe in kids, Omicron is less severe, but, I'm starting to wonder whether or not severity, by the fact that we are this far into the pandemic and now with a pretty robust and available vaccination program, I wonder if we're not articulating as well the importance of vaccination because we're saying things seem less severe nowadays than before. I think it's really important for the public to know that the counterfactual might not be true. We could be in the same situation today as we were in the very beginning of the pandemic if we didn't have vaccines available. So just, again, an ask to continue to do our best to look at that data to understand if it really is variant specific. How much is it due to the variant versus how much is it due to where we are in this vaccination program and in the pandemic 2 years in? Because it does feel like the messaging, comes across differently in the more recent waves. The other, piece related to that and the younger kids is, a lot of younger kids were protected for the longest period of time because we had so many other mitigation measures in place. So it wouldn't be unanticipated that this population of kids who didn't have access to vaccine and who perhaps were protected fairly well until recently would suddenly have a surge of hospitalizations and severe illness. Also, these younger kids, I suppose it doesn't surprise me because we know that younger kids have smaller airways and they have a little bit less reserve, that they would come in, healthy kids otherwise would have come in with severe disease. So again, highlighting the importance of prevention in this arena. And then the final thing, I was thinking and reflecting on the question, and that I think it was Dr. Paling that asked about disparities by race, ethnicity with regard to hospitalization. I certainly think that there are disparities that exist. But I also wonder about disparities in testing and disparities in circulating rates of infection. And so, how much of that information can continue to help us by highlighting the importance of testing, the importance of having tests available, and really appreciate the government's efforts to continue to make that available to the public. Without access to testing, it's going to be really hard to interpret this information in a robust way. So, are individuals where we see the disparities at higher risk for severe disease, or is it that the background rates of infection are just so high that we are seeing more of them coming in proportionately, becoming hospitalized or with severe illness? I think both could be true, but just it's hard to disentangle this data from what we're able to see today. So just an ask if it's possible to continue to look at that data more critically.
Thank you for all of that.
Dr. Sanchez?
Thank you. Thank you. And really, it's a great presentation and appreciate it. I was just impressed with the seroprevalence data. What I remember is that 6 months to 4 years of age, there was a 71% positive seroprevalence. And I mean, that to me was pretty amazing. And first of all, I liked a little bit of information about the study, the United States, how that reflects the general population of children, to see how inclusive it is. Because if that really is the general seroprevalence data that we're seeing in this age group, our message will also have to change. And I know we'll hear more about the recommendations and what we think, but this natural immunity and the fact that that a lot of these children will be getting vaccinated despite the fact that they've had it before, which we know we are recommending in the older children and adolescents. So I'd like a little bit more information on that seroprevalence data because it really was kind of amazing, 71%.
Yes, and can we have slide 10, please? And while you're pulling that up, I believe either Dr. Jones or Dr. Clark may be on, who can speak more to the methods of that study.
Hi, yeah, this is Dr. Christy Clark. So thanks so much for this question. Yeah, it really is important information. And in the population of children 6 months to 4 years, you can see that since December 2021, the seroprevalence or the proportion of that population that has antibodies induced by a prior infection with SARS-CoV-2 has more than doubled, gone from 33% to 71%. Now, regarding methods for this study, all of the samples, all of the estimates are adjusted for the ages of children, for the sex of children, and for rural or urban status of their county of residence. In order to make the results as representative as possible. Now, it is calculated from samples that were submitted for clinical testing at commercial labs. So we did some analyses that are available in the preprint that you see referenced on this slide to look at some potential sources of bias of looking at commercial lab specimens in this age group. Given that, some children may require more frequent healthcare monitoring than other children. And what we found in that study was we compared children who had ICD-10 codes or were getting lab tests that may have been more likely to indicate that they're getting child care or more routine care, and compared that to other pediatric samples. And we actually found that the seroprevalence among those groups of children are fairly close, and actually just a very slightly higher seroprevalence among those kids who were seeking things that were more likely to reflect child care or more routine monitoring care. And so we don't believe that that children who are seeking more frequent healthcare monitoring due to special health conditions are a significant source of bias for these samples. And as I said, they are weighted for several demographic factors. So I hope that that's helpful in your consideration of these data. Thank you.
Thank you. Ms. McNally?
Do you mind if I just add a little bit to that?
Of course.
So I just wanted to let you all know that we will, or Dr. Oliver tomorrow will be talking a little bit more about how this will fit into the context of the vaccine recommendations. So stay tuned for that tomorrow. And I think Dr. Jones might also be on the call. I don't know if you wanted to add anything else.
Sure. I mean, just a quick blurb about the benefits of the evidence of the vaccination after infection. So infection-induced protection against infection appears very poor against Omicron infection, and it wanes over time, although not as quickly as vaccine-induced protection. And although infection-induced protection against severe disease appears to be more robust, evidence has consistently shown that vaccination in those previously infected substantially boosts protection against both infection and against severe disease. And some of that data will be presented later.
Thank you. Ms. McNally?
Thank you. Dr. Fleming-Dutra, I'm not sure if this question is more appropriate for you or for the next speaker, but I'm wondering about the impact of vaccination in this age group on community immunity or herd immunity. Thank you.
Thanks for that question. I think it's really important. I probably will defer that question to following the next presentation regarding vaccine effectiveness.
Thank you. Dr. Brooks.
Yes. First of all, I think this is a really important presentation, and the one in front of it, framing the issue. I think that's we need to understand the need to get these children vaccinated. My question and comment is related to the disruption based on job continuation. Can you speculate on why you think the higher rates among African Americans and the Latinx are there? Is it higher rates of exposure of COVID-19 of the children? Is it the particular employment? Is it the inability to work from home? I'm just curious about that particular data because I think that's overlooked, the effect beyond illness, but on everyday life of the families.
Thank you for that. And can I have slide 38? I have to, these data are from the Kaiser Family Foundation, and it's an excellent question as to why certain groups of parents are more impacted by job disruptions, either leaving a job or changing work schedules to take care of their children. The particular source did not go into detail about why certain parents were more likely to be impacted by job disruptions due to childcare. And so, well, I think it's a very interesting question. I'm afraid that I would have to speculate, and I don't want to do that without data to back it up. But it's a very important question.
Thank you.
Thank you. I think at this time we will move on to the next presentation. Dr. Ruth Lingelis to review updates on vaccine effectiveness in children and adolescents, and look forward to coming back to Ms. McNally's question after the presentation.
Great, thank you so much. Today I'll be sharing updates on COVID-19 vaccine effectiveness during Omicron for children and adolescents. Next slide. I'll start first with CDC's PROTECT platform. This is a prospective cohort study in children aged 4 months to 17 years that includes weekly swabbing regardless of symptom status, so should not be impacted by changes in testing practices due to the availability of home tests. The study uses a Cox proportional hazards model with adjustment for propensity to be vaccinated, site, SARS-CoV-2 circulation, and community mask use. Results were separated by age group, 5 to 11 years and 12 to 17 years. Next slide.
Dr. Lingelis, would you be able to step a little closer to the microphone?
Sure, is this better?
Yes, thank you.
These results are updated from the Folks et al. MMWR published in March and extend those findings through April 23rd. Here we have VE against infection for 5 to 11-year-olds on the top and 12 to 17-year-olds on the bottom, further separated by time since last dose. Note that for the 5 to 11-year-old group, there was not enough power in the 60-plus days after the second dose, and so the confidence interval was too wide to make meaningful conclusions, so we have not included that estimate. Comparing the early post-second dose period, note that although the point estimates are different for the two age groups, the confidence intervals for the adolescent group overlap entirely with the confidence intervals for the kids, though the time intervals are a bit different. In the adolescent group, a booster dose provides a significant increase in VE, bringing VE up to 83%, a median of 95 days or more than 3 months after the booster. Next slide. Moving on now to the Increasing Community Access to Testing, or ICAT platform, which is a national community-based drive-through testing platform with data from pharmacies. This platform relies on self-reported vaccine history and uses a test-negative design where cases are persons with at least one COVID-like symptom and positive NAT test, and controls are symptomatic with a negative NAT test. Models are adjusted for the variables shown here. We present data on adults first to show the differences between Delta and Omicron. Adults were tested from December 10th through January 1st with Omicron determined by S gene target failure. Tests in kids were included between December 26th and February 21st, when almost all circulating disease in the country was Omicron. These results have been previously shared with ACIP, but we've included them here for completeness. Next slide. This is previously published adult data for Delta in orange and Omicron in blue by time since the second dose, shown on the x-axis, with VE on the y-axis and the dotted lines showing the 95% confidence intervals. You can see the lower starting VE for Omicron and much quicker waning compared to Delta, including 0 in the confidence interval by 3 months after the second dose. Next slide. Now we show the same adult Delta and Omicron data and overlay data from adolescents 12 to 15 years of age in black and children 5 to 11 years of age in pink. Note the shorter follow-up time for the 5 to 11-year-olds due to vaccine being recommended for them in November. Generally, we see very similar patterns across the age groups, with 2 doses of mRNA vaccines providing roughly 60% protection initially and quickly waning by a few months after the second dose, reaching 0 by 3 to 5 months after the second dose. Next slide. These are updated data from what I've previously shared with ACIP. We're concentrating here on just the 12 to 15-year-old group, and in black we have the same 2-dose VE as shown on the previous slide. We've now overlaid the 3 versus 2-dose relative VE for the same age group in blue. We continue to see waning against symptomatic infection even after the third dose, though not quite as extreme as after the second dose. Next slide. Moving on now from VE against infection to VE for emergency department and urgent care visits and hospitalization. The VISION network is a multi-state network based on electronic healthcare records. Like ICAT, it uses a test-negative design with cases having CLI and a positive PCR and controls having CLI with a negative PCR. VE is adjusted for propensity to be vaccinated weights, calendar time, region, local virus circulation, and age, and vaccination is determined via health records and state and city registries. Next slide. This is an update to data included in the Klein et al. MMWR in March, showing VE against emergency department and urgent care for children 5 to 11 on the top and adolescents 12 to 15 on the bottom. For the 14 to 59 days after the second dose, we see almost identical VE point estimates in the two groups, 50 to 56%, with wider confidence intervals for the adolescents since it's been much longer since they were recommended to be vaccinated. The adjusted VE drops substantially for adolescents 60 days after vaccination. On the bottom of the slide, I've noted the case definition for an ED-UC visit, which highlights here the potential for inclusion of children visiting urgent cares and EDs with COVID instead of for COVID, likely a bigger concern for kids than for adults, as the case definition includes GI symptoms, which may have many frequent non-COVID causes in kids and could potentially drive the VE estimates for ED and UC closer to those of infection in kids. As with the infection estimates, a booster dose provided a significant increase in VE among 12 to 15-year-olds, 73%, up to a median of 58 days after the booster. Next slide. Here we have VE of 2 doses against hospitalization for children 5 to 11 and adolescents 12 to 18 years of age during Delta and Omicron. This slide has been previously shared with ACIP and published via MMWR. Updated data were not available due to the relatively few children hospitalized once the initial Omicron wave subsided. For the 5 to 11-year-old group, you can see that there were only 2 hospitalization breakthroughs during the study period, which included 2 months after children in that age group could be fully vaccinated. While the point estimate for 5 to 11-year-olds, 74%, is lower than the point estimate for 12 to 15-year-olds, 92%, that's likely because the younger age group included 67% Omicron cases, for which VE is lower compared to earlier variants, while the older age group included only 15% Omicron cases. Next slide. Finally, I'll show results from the Overcoming COVID platform. Overcoming COVID is a test-negative VE platform specifically aimed at children and adolescents hospitalized at 31 pediatric medical centers in 23 U.S. states. As with other platforms, cases have CLI and a positive test, while controls have CLI and a negative test. Vaccination status is determined using a combination of documentation in the medical record and self-report and modeled via logistic regression. Next slide. This is an update to a recent publication in New England Journal of Medicine. We see VE for 5 to 11-year-olds of 68% to a median of 37 days after the second dose, and VE for 12 to 18-year-olds of 51%. In the older kids, we can see VE split by time since vaccination, with some indication of waning at 23 to 45 weeks. Unfortunately, uptake of booster doses in adolescents was not high enough to assess additional protection against hospitalization afforded by the booster dose. Next slide. Here we have updated data on VE against MIS-C for both age groups, with a VE of 78% for kids and 90% for adolescents. Again, I would note that similar to the estimates shown for vision and hospitalization, the 12 to 18-year-old estimates likely comprise many more Delta cases compared to the younger age group, which likely accounts for the higher VE for the older kids. We do not see a signal here for waning in the adolescent group, and similar to hospitalization, we did not have enough power to assess additional protection due to a booster. Next slide. In summary, VE against infection for two-dose VE declined quickly for children and adolescents during Omicron and followed a similar pattern to that of adults. A booster dose in adolescents substantially improved VE compared to 2 doses, though some waning appears evident. A similar pattern was noted for emergency department and urgent care visits, with VE similar after 2 doses in both age groups, with evidence of waning and substantial additional protection from a 3rd dose among adolescents. Finally, for severe disease, 2 doses provided protection for both children and adolescents, with some waning evident for hospitalization in adolescents. There was not enough power to assess waning in children or the impact of boosters against hospitalization or MIS-C in adolescents. Next slide. I'd like to acknowledge the individuals shown here, and I'm happy to take questions. Thank you.
Thank you, Dr. Lynn-Gillis, and this presentation is now open for questions. Ms. McNally.
Thank you. I am wondering about the impact of vaccination in this age group on community immunity or herd immunity. Thank you.
Sure. I think that's a pretty complicated question given the presence of new variants. We know that protection from both prior infection and from vaccination is not 100%, and even children and adults with evidence of past infection and past vaccination can get reinfected. So I think at this point, it's a little bit of a misnomer to talk about herd immunity as something that will, substantially reduce Omicron circulation. Vaccine does have a substantial impact on infection initially. We do see that wane, but that vaccination protection is maintained against severe disease. And we know that individuals that have a prior infection and then do go on to get vaccinated do see a substantial increase in protection, which gives them broader protection against a wider array of variants, including the original as well as whatever circulating variant they were infected with.
Dr. Paling.
All right. I want to say thank you for this great presentation and summarizing so many different studies. And I wanted to verify that my interpretation is correct. So as I am looking at the data for both age groups 5 to 11 and 12 to 17, if the primary outcome is the presence of any case of infection, that wanes pretty quickly. But when you start to look at ED visits, it wanes but is higher and stays significant. And then when you get to hospitalizations, that maintains minor, much smaller amounts of waning. And then importantly, that the vaccine is protective against MIS-C. Is that a correct interpretation? Thank you.
Yes, I think that's absolutely correct. And it's important, I think, to emphasize here that the patterns that we see in children and adolescents are essentially identical to the patterns that we see in adults. So during Delta, for example, we had higher vaccine effectiveness against infection, but that has decreased during Omicron. But during the Omicron period, where we do see, as you mentioned, quicker waning against infection, we see higher vaccine effectiveness for EDUC and even higher for hospitalization and the highest for MIS-C. And that's the same pattern that we see in adults, where the most severe, most critical outcomes have the highest vaccine protection.
Thank you. Dr. Daly.
Yeah, thanks so much. Could you go back to your summary slide? So I think what we've heard from parents, especially parents who have some, concerns, they want a full conversation of what's known and what's not known. So I wonder if you could just highlight for us again. I think I caught this, but kind of where the gaps are. You highlighted this, but kind of where the gaps are and when we might expect data about those gaps. Gaps in knowledge about prevention of hospitalization, severe disease in particular. Thank you.
Yeah, absolutely. I think it's an important point. So one gap I think that we've identified is especially for the more severe endpoints waning in the 5 to 11-year-old group. And that's primarily just because of the timing of when they were vaccinated. And so many children were not yet fully vaccinated during the height of the Omicron wave in January. And so by the time those children became fully vaccinated and were eligible for inclusion in these studies, the BA1 wave of Omicron had mostly subsided. And so we just didn't accrue enough cases within our platforms to look at that. Unfortunately, with the current surge that we're seeing and BA4 and 5 picking up, I would expect that we would have additional power to look at waning in the 5 to 11-year-olds over the summer. And we plan to continue to look at that, and we'll circulate back to ACIP if we have that. The other missing piece, I think, also related to coverage is the booster dose for 12 to 15-year-olds. And that was also just due to the timing. They were recommended to be boosted in January. And so we didn't accrue a lot of cases in that age group during the Omicron wave. I will also emphasize that in both of these age groups, low coverage has often prevented us from assessing vaccine effectiveness. And then we also don't have estimates yet for boosters in 5 to 11, and that's, of course, because they were only recently recommended for that. So all three of those gaps, I think, we'll continue to assess over the summer and circle back to ACIP when we have meaningful estimates.
Okay, thank you so much. Dr. Lee, can I then ask a follow-up question?
Of course, Dr. Daly.
Then can you just then remind us about vaccination with a booster as a means of preventing severe illness in adults? Because in some ways that it doesn't entirely fill in that gap, but I interpret that gap in the context of what we've learned about prevention of severe illness in adults. Over.
Yeah, absolutely. And so we know from the infection data, where we do have a lot more data on kids, that kids are following an almost identical pattern to adults. So I think it's a fair assumption that we would see similar patterns against severe disease in children as in adults. And in adults, we know that 2 doses during Omicron does give some protection, but wanes more quickly. A third dose largely restores protection that the 2 doses initially afforded, and then we see much slower waning of the third dose compared to 2 doses. So for those 5 to 11-year-olds and 12 to 15-year-olds that have not gotten vaccinated, a primary series is going to provide a great initial protection against Omicron, but a booster dose will give them longer lasting protection.
Thank you. Any other questions? Well, we're waiting to see if other hands are raised. I have a question / comment, sorry, and I'm trying to think about how to ask this. One of the challenges that we've had with vaccine effectiveness studies is the limited variability in terms of dosing intervals for vaccines. And, you know, part of me, we've only actually had Pfizer vaccines to date for kids that are younger. So I wonder about this 2 versus 3 dose question. It does seem like the data you showed gives us some evidence that 3 doses might be preferable, and whether or not it's a booster or a part of a primary series, I guess, is the question, and perhaps just a semantics question. But I do think that, you know, I feel still challenged by the fact that maybe 3 doses should have been the baseline to begin with. And the other question that's a sub-question of that is whether or not longer intervals between dose 1 and dose 2, and then the same question holds between dose 2 and dose 3, would give us a greater sense or greater effectiveness overall, and perhaps longer durability of immunity. So just wondering if that is something that you can continue to look at, recognizing we have very limited variability in dosing intervals. But that information to me still seems important about whether or not additional doses are needed, additional booster doses are needed.
Yeah, thank you, Dr. Lee. I think that's an important question. It's something that we have looked at repeatedly in a number of our platforms in the United States, and I'm aware of international data showing higher effectiveness with further spacing of the vaccines, but in the US, individuals followed pretty closely the 3-week interval for Pfizer and 4-week interval for Moderna, and so we just haven't had enough variability in our own data to look at it.
Yeah, so maybe it's a question back to Pfizer and Moderna to ask about whether or not those dosing interval studies could be done to give us a better sense of how to make this immunity more durable. Dr. Long.
Yes, thank you. This is somewhat related. Can you find the slide that you show us the trajectory of waning for 3 doses versus 2 doses in olders? I jotted down for my own, although you mentioned that waning is slower following the 3rd, I had jotted down that it looks like the same trajectory, it's just that you're starting higher. So would you comment on that? I mean, you don't have I don't know how many people you have here, 4 months, to know, does it really level off there or does it continue? How confident are you? It's just a question of the rapidity, the trajectory of fall. Is it really going to be better following the 3rd dose, that it's more sustained, or you're just starting at a higher level? And for me, this also pertains a little bit to think about if 70% of the children that we would administer a vaccine to have had their first infection, does that first dose act a little bit more like a 2nd dose and the 2nd dose act like a 3rd dose? So I'm wondering in the data that we have, and we'll see from the manufacturer, about how many they knew were or weren't seronegative at the beginning. But anyhow, so how do you interpret this trajectory of fall?
Yeah, sure. I mean, I think you're right. I think there's slightly higher starting VE and then slower waning, potentially with, you know, it's sort of bottoming out a little bit higher than it did for 2 doses. It doesn't quite get down to 0. So there's the potential there that we would see a little bit more lasting protection of some degree in 3rd dose vaccines. But I think we just need a couple of more months of data accrual there. And then, of course, at 5 months, So I think we just need a couple of more months of data accrual. As far as prior infection, for this particular analysis, we did exclude individuals who reported a prior infection. So these should be, individuals with no history of prior infection receiving a true 2-dose or 3-dose series. I believe that there will be more information shared specifically about protection from prior infection during the meeting tomorrow.
Thank you.
Thank you. Dr. Lair?
Thank you. I would like to second Dr. Lee's comments on the 3-dose series and the possible increasing spacing between the vaccines. This is more a comment, and I don't really expect an answer, and it might be a comment for the FDA, but I'm not sure how we're ever going to get the data or the information that's going to tell us that this is really a 3-dose series, or that we should be spacing the first 2 doses by 2 months. I want to thank the manufacturers for getting the vaccines out as quickly as possible, and they found out that this pattern worked, and it was wonderful to have these vaccines, but we don't know if what we have right now is the best way of giving the vaccines. And I'm not sure how the FDA or the ACIP is going to figure out the best way, or if there is a best way. But Dr. Plotkin brought this up many, many months ago, probably over a year ago, that this really might be a 3-dose vaccine all along, and we just started off with 2 doses because that worked and that allowed us to vaccinate the population. So I'm curious, interested if anyone has any ideas on how we are going to get that information to find the best way of vaccinating our population. Thank you.
Yeah, I mean, I think in the US, it's unlikely that we'll have real world data just because people have been following the recommendations pretty closely. So I think we would have to rely on international data.
This is Jordan Fink from FDA. I'll just jump in that, yes, I agree that we're unlikely to get relevant data from the US. And so we will have to look at international real world data, but this is something that could be studied by the vaccine manufacturer, looking at different dosing intervals. And you asked, I think you asked a couple of different questions. One related to the optimal dosing interval, and then one related to, is this a 2-dose regimen or a 3-dose regimen? And we've had to adjust and build on to our authorizations and our labeling as we go along. And I hope that one of the things we have an opportunity to do over the summer, as we're preparing for a fall vaccination campaign and potentially a change in vaccine strain composition, although that remains to be determined. I hope that we have some time to take a step back and really think about what makes the most sense in terms of regimen, and try to simplify things a little bit for patients and healthcare providers. Over.
Thank you, Dr. Fink. That was really helpful. Yes, I mean, I think you're right. This question is answerable, and we still have opportunity because we still have a lot of children who are not yet vaccinated and who will likely receive, more than 1 dose or 2 doses or 3 doses of COVID vaccines over their lifetime. So I think this is really helpful, and it's still an opportunity for us to study this. And so look forward to our manufacturers presenting and to hear their thoughts about this. Dr. Paling, and then we'll go to break.
Okay. Dr. Legelis, one of the things that we've been thinking a lot about is children or people across all ages that are immunocompromised. Fortunately, that's not a huge population in children, but do you have any insights about VE among children who are immunocompromised? Thank you.
Sure. Yeah, I mean, generally, we just have not had power to separate by immunocompromised status in any of our platforms to look at VE. I mean, I would refer back to Dr. Fleming-Dutro's presentation and note that, over half of these hospitalized kids do not have underlying conditions. And that's generally been true, even amongst the vaccinated. What we see is that hospitalized kids tend to have more underlying conditions of the general population, but certainly not all. And then for immunocompromised in particular, I would say that, just like with general VE, I think we would expect it to follow a similar pattern to adults, where we do see lower vaccine effectiveness amongst immunocompromised adults, and that's why there's the additional primary series dose and now an additional booster dose recommended for them. And so I would refer to tomorrow, where I think we'll talk about the dosing regimens and additional doses for immunocompromised.
Thank you. And with that, we will break. I want to thank our speakers again, and thank you for the robust discussion today. We will break until the top of the hour, so 12 p.m. Eastern Standard Time, 9 a.m. Pacific Time. Thanks, everyone. Thank you, everyone. It's at the top of the hour, so I'm going to suggest we reconvene our meeting and get started. First, we will have Dr. Rituparna Das from Moderna presenting on the Moderna COVID-19 vaccine mRNA 1273, safety, immunogenicity, and efficacy in children ages 6 months through 5 years of age. Dr. Das, the floor is yours.
Great, thank you so much. And I will share my screen and let me put it into presentation mode. Great. All right, good afternoon. My name is Rita Das, and I'm the Vice President of COVID-19.
Do you mind just swapping it where you can see?
Oh, sorry, thank you.
You're totally fine.
All right, is that better?
Yes, perfect, thank you.
Oh, great. So we're here today to discuss the use of mRNA 1273 as a 2-dose primary series for the prevention of COVID-19 caused by SARS-CoV-2 in young children 2 to 5 years and infants and toddlers 6 to 23 months of age, where, as Dr. Fleming-Dutra just showed, the greatest increase in the burden of hospitalization with the Omicron surge was seen. The proposed 2 doses at the 25 microgram per dose level are to be administered 1 month apart. Our data in these age groups comes from study 204, where more than 6,500 infants, toddlers, and young children were enrolled, and more than 5,000 received at least 1 25 microgram dose of mRNA 1273. Overall, this represents a substantial safety database for these groups. The median safety follow-up times in both age groups are more than 2 months. In the early cohorts, which is the dose-finding part of the study, we have children with 7 to 8 months of median safety follow-up. Study 204 was conducted in 2 parts for each of the age strata. Part 1 was an open-label dose escalation study and was conducted first to select a dose level for further testing in Part 2, which was the placebo-controlled part of the trial. Both 25 and 50 micrograms were studied in the 2 to 5-year-old children. The 25 microgram dose was chosen for these older children, so the 50 microgram was not investigated in the younger children. Overall, the 25 microgram dose was chosen for both age groups because it showed an acceptable tolerability profile and demonstrated a high likelihood of meeting the pre-specified immunogenicity success criteria for the study. After Part 1 was completed, a DSMB meeting occurred to ensure the committee's concurrence with the selected dose. Part 2 was designed to randomize the children in a 3-to-1 ratio to receive either mRNA 1273 or saline placebo. The children will be followed for 12 months after receiving their last dose of vaccine. The data we will present today focus on the randomized phase of the study. Overall, the demographics were well balanced between the vaccine and placebo in both age groups. The mean age in the youngest group was approximately 16 months, and it was 3 years in the older age group. Gender, race, and ethnicity also were well balanced. On to the safety from the study. The specific safety objectives included solicited local and systemic adverse reactions collected for 7 days post-vaccination. Unsolicited adverse events were captured for 28 days after each vaccination, and serious adverse events, medically attended adverse events, and adverse events of special interest, including myocarditis, pericarditis, and MIS-C, were followed throughout the entire study. Starting now with the local reactions in children 2 to 5 years of age. In this figure, mRNA 1273 is shown in blue, and the placebo is shown in gray. Pain was the most common event with similar rates and severity following dose 1 and dose 2. Most local AEs, including pain, were grade 1 or grade 2 with few grade 3 reactions. The median duration of local adverse reactions in this age group was 2 to 3 days. Looking at the infants and toddlers 6 to 23 months old, pain again was the most common local adverse reaction although reports of pain in this youngest group were more similar to placebo, both post-dose 1 and post-dose 2, compared to the older age group. Systemic adverse reactions were evaluated according to age. Young children's events were fever, headache, fatigue, myalgia, arthralgia, nausea, vomiting, and chills. For infants and toddlers, the events were fever, irritability and crying, sleepiness, and loss of appetite. Headache and fatigue were the most common systemic adverse reactions in the children's 37 months to 5 years. Among the vaccine recipients, systemic adverse reactions were more frequent post-dose 2 compared to post-dose 1, although this difference was less pronounced than we've seen in older age groups. Duration was 2 to 3 days, very consistent with other age groups. In this slide, we're showing the systemic adverse reactions collected for infants and toddlers. On the top are the 24 to 36 month group, and on the bottom are the 6 to 23 month group. Here, reporting rates of systemic adverse reactions were similar between dose 1 and dose 2. Also, these systemic events were reported at similar rates among vaccine and placebo recipients. I will discuss fever separately since this is a particularly important event in the assessment of pediatric vaccines. This slide shows fevers by increment among children 6 months through 5 years. Overall, fever after any dose occurred in about a quarter of the children. The distribution of temperatures was similar between the two age groups. Fevers of greater than 40 degrees Celsius were rare. In this slide, we have the maximum temperatures post-dose 1 and post-dose 2 according to temperature ranges shown on the top. On the top are fevers in the children 2 to 5 years. We see the fevers occurred more frequently following the second dose. It's important to note that most reports of fever were less than 39 degrees Celsius. On the bottom are fevers in the infants and toddlers. Again, fevers are reported more commonly post-dose 2. The rates of fever greater than 39 degrees in this youngest group are similar to placebo. This next figure shows fever by day after the second dose in children 2 to 5 years of age. Most events of fever occurred within 2 days following vaccination. Beyond day 2, we see that fever rates in children receiving mRNA 1273 are similar to placebo. The median duration of fever in this age group was 1 day. It's important to note that this study was conducted during the winter months, when respiratory tract infections are prevalent. This is evident by the relatively high rates of fever that we observed in the placebo group. We see a similar pattern in infants and toddlers, with the peak of fever occurring on days 1 and 2 after vaccination. On subsequent days, fevers look similar across the vaccine and placebo groups. The higher background rate of fever is even more prominent in the infants and toddlers. There were 15 children with fever greater than 40 degrees Celsius in the mRNA group and 3 in the placebo group. The peak temperature of greater than 40 degrees Celsius had a duration of less than 1 day. Of the 15 vaccine recipients, 6 of the children also had symptoms of concurrent viral infection. There was one febrile seizure which occurred proximal to vaccination and was considered related by the investigator. You'll recall that febrile seizures can occur actually in up to 5% of young children. The child in the study also had a maculopapular rash onset 2 days after the seizure and went on to have a subsequent seizure associated with another fever approximately 6 weeks later. The child has remained in the study and received dose 2 of the vaccine without events. Next, I'll discuss unsolicited adverse events. Presented here are the events reported up to 28 days after any injection in children 2 to 5 years. The incidence of unsolicited AEs was similar among vaccine and placebo recipients. There were no SAEs considered to be related by the investigator. Incidence of medically attended AEs were similar, and there were no AEs which led to discontinuation of the vaccine or from the study. After the data cut, one event of urticaria was reported on day 1 post-vaccination that did lead to discontinuation. There were no events of death or adverse events of MIS-C or myocarditis. Among the infants and the toddlers, the incidence of unsolicited AEs overall and the MAAEs were similar among vaccine and placebo recipients. There was one SAE within 28 days, which was considered related to vaccination, which I already described in the fever discussion. Since the data cut of our submissions, which was in late February, we pulled the SAEs from the live database in early May to provide further reassurance of the long-term safety of mRNA-1273. The updated analysis did not identify any new safety signals, and there were no SAEs which were considered by the investigator to be related to vaccination. Next, we'll turn our attention to the immunogenicity data. Vaccine effectiveness was successfully inferred by meeting the predefined co-primary immunogenicity objectives, which were agreed with the FDA. These included geometric mean concentration and the difference in seroresponse. In each age group, immune responses were compared to the 18 to 25-year-old immunogenicity subset from the 301 study, where primary efficacy of the vaccine against any and severe COVID-19 disease was demonstrated. In the middle of this slide is the immunogenicity from children 2 to 5 years. The two co-primary immunogenicity objectives were met for these children. The ratio compared to young adults was 1.01 with a lower bound of 0.88. The seroresponse rates were close to 100% with a difference of minus 0.4% with a lower bound of minus 2.7%. Now looking at the infants and toddlers 6 to 23 months of age on the left column in the lightest blue, we see again that both co-primary immunogenicity endpoints were also met. The ratio compared to young adults was 1.28 with a lower bound of 1.12. In addition, the seroresponse rate was 100%. The group difference of 0.7% was seen with a lower bound of minus 1.0%. The immune response to mRNA-1273 has been remarkably consistent across age cohorts despite administering lower doses to young children. This slide depicts the immune responses ranging from young adults, 18 to 25, through the youngest children in our pediatric program. Across these age groups, the ratio ranges from 1.01 through 1.28, successfully meeting all primary immunogenicity hypotheses in all age groups. Additionally, support for vaccine effectiveness was provided through assessments of efficacy in our study, which were secondary, which demonstrated that in all age groups, we had comparable effectiveness to adults when the variants were matched. Although we did not observe any severe cases of COVID-19 in the children at the time of the data cutoff, this consistency leads us to believe that protection against severe disease will be comparable to adults, which will be evaluated in post-authorization effectiveness studies. So to expand upon this a little, we can see here how the studies were conducted as the SARS-CoV-2 epidemic pandemic in the U.S. was changing. This is important when interpreting the efficacy results in our two youngest age cohorts. The enrollment and efficacy follow-up in the youngest children was conducted when the Omicron variant was predominant. And the impact of the Omicron daily incidence is apparent from the curve that's shown in red. From December 2021 through March 2022, the U.S. incidence of SARS-CoV-2 infections rose from fewer than 200,000 per day to a peak of 1.4 million cases per day, which is when these youngest cohorts were followed. Moving now to the efficacy results. While the study was not powered for assessment of efficacy, we were able to get good efficacy estimates given the high rates of community SARS-CoV-2 transmission when the randomized cohorts were conducted. Two case definitions for COVID-19 were used. First, the CDC case definition, which required at least one symptom, and then the Study 301 case definition, which required two systemic symptoms or one respiratory symptom. The CDC case definition was considered primary since children tended to have less severe symptoms of COVID-19 than adults. Of note, both definitions required a nasal swab positive by RT-PCR for SARS-CoV-2. We took a comprehensive approach to capturing cases. Efficacy estimates in the young children are based on 180 cases captured over 71 days post-dose 2. Beginning with the children 2 to 5, there was a lower incidence of COVID-19 by both definitions in children who received vaccine compared to those who received placebo. Statistically significant vaccine efficacy of 36.8% was observed using the CDC definition. When we get to the P301 case definition, we see how the number of cases is reduced, but efficacy of 46.4% is observed. This is also demonstrated by the cumulative incidence curve for COVID-19 by the CDC case definition, and this is in the MITT1 set. The mRNA group is depicted in red and the placebo is in blue. The separation of the lines is observed shortly after dose 2 of the vaccine, which is evidence of the early onset of protection. Next, looking at efficacy among infants and toddlers 6 to 23 months. Efficacy estimates here are made on 85 cases captured over 71 days post-dose 2. We see again statistically significant efficacy of 50.6% when the CDC definition is used. When we see the P301 definition, the point estimate is directionally similar and the confidence intervals are wider due to the drop in the number of cases. To that end, at the start of the Omicron wave, we noticed that parents were reluctant to bring the youngest children into the site for illness visits. Instead, they were calling in results of positive home antigen tests. So since we also captured the results from home antigen tests, we did a sensitivity analysis defining COVID-19 either by positive PCR or home antigen tests. With the increased number of cases captured, the confidence intervals narrow, and the point estimates for efficacy are 53.5% and 43.7%, with the confidence intervals excluding 0. This is also demonstrated in the cumulative incidence curve for COVID-19 by the CDC case definition in the younger age groups as well. The mRNA group is depicted in red and the placebo is in blue. The separation of the lines again is observed shortly after dose 2, evidence of the early onset of protection. For context of the efficacy, we'll now look at real-world effectiveness in adults during the Omicron surge to help interpret the vaccine efficacy from our pediatric program. Presented on the left are the real-world effectiveness data against Omicron after a 2-dose primary series among adults. These data are from our collaboration study with the Kaiser Permanente Health System. Vaccine effectiveness of mRNA 1273 against COVID-19 was 44% when the Omicron variant was predominant. On the right are the estimates of efficacy from Study 304 in infants and young children. Efficacy of mRNA 1273 was consistent with effectiveness observed in adults. While vaccine effectiveness against any infection was lower during Omicron, we continue to see that the benefits of mRNA 1273 continued against hospitalization. 2 doses of mRNA 1273 was shown to be 84% effective against hospitalization during the Omicron period. This is important because we would expect the same level of protection in children given the consistency of the immune response and the efficacy with adults. Study 204 is ongoing and safety follow-up will continue for all participants. Children will all be offered a booster dose after their second dose, and they will be boosted either with mRNA-1273 or our bivalent Omicron-containing vaccine. So in summary, mRNA-1273 was well tolerated. Local and systemic reactions were seen less frequently in these youngest age groups. Solicited adverse reactions were mostly grade 1 or 2 and slightly more common after dose 2. Fever was reported in about a quarter of children and most commonly seen on days 1 or day 2 after each dose and resolved within 1 day. No deaths, myocarditis, pericarditis, or MIS-C were reported among vaccine recipients. There was one related SAE of fever, febrile seizure within 28 days of any vaccination. The primary immunogenicity objectives were met. 2 doses of mRNA-1273 were shown to be immunogenic. GMCs and seroresponse rates were non-inferior to young adults. Vaccine efficacy can therefore be successfully inferred based on immunogenicity. In both age groups, direct efficacy against COVID-19 was observed during the Omicron period, again consistent with effectiveness observed in adults. Based on the information we've shown here today, we've demonstrated that the benefit-risk profile for mRNA-1273 is strongly favorable in children 6 months through 5 years of age. I'd like to take a moment to acknowledge all our study investigators, site personnel, our colleagues at BARDA and the COVIPN and NIH, and really most importantly, the infants, toddlers, and children who participated in the trials and their families. Without you all, our pediatric program would not have been possible. Thank you very much, and I'll be happy to take any questions.
Yes, this presentation is now open for questions, and I see Dr. Peeling has her hand raised. Please go ahead.
Thank you, Dr. Das, for a very clear and informative presentation. I've got 2 questions. The first is, could you clarify what the placebo is? And then the second is, we saw that some children probably had COVID-19 in the past. And do you have any data about those that were seropositive before being vaccinated? Thank you.
Yes, absolutely. So the placebo was saline. And then let me pull up a slide. We had about 6 to 8% of children with baseline either seropositivity or a day 1 SARS-CoV-2 positive from a nasal swab. And so we had immunogenicity data from those children as well. And I can share them now. Okay, here we go. Okay, and you see here, so make this a little bit larger. Yeah, you see here that the, for the seronegative, I'll call them seronegative, we had for the 2 to 5 years, the GMC was 1425. For the seropositive children, it was over 6,000. And for the 6 to 23 month old, for the seronegative children, their GMC was about 1,700. And for the seropositive children, it was much higher.
Thank you. I see Dr. Sanchez.
Yes, thank you for that presentation. So getting back to Dr. Paley's point, the data that you have presented, did it exclude the ones who were seropositive?
No. We included them for, we did not, the seropositivity was checked at trial entry, but it was not an entry criteria into the trial. So
the data you presented earlier, it included both.
Yes, so the safety data I presented did include both. The immunogenicity data I presented only includes per protocol immunogenicity, which is only the seronegative. And then I just showed the seropositive immunogenicity data as well. I can put that one back up. And
no, that's okay. I just wanted to clarify.
Okay.
But actually, I had another question. In the 6 to 23 months, where was the vaccine administered?
So it was left to the to our investigators' discretion to be administered in the arm or in the thigh.
And so we only saw data about axillary swelling. If it was administered in the thigh, was there any inguinal adenopathy seen?
Yeah, so for those youngest, actually we allowed thigh administration, I think, through both age groups. Oh. And our swelling was measurement was proximal to the site. So the question that was given to the parents and to the investigators was axillary or groin swelling.
So then you did see some inguinal swelling or groin swelling?
Yes, we did.
Thank you.
Thank you. Ms. Bata.
Thank you. And thank you, Dr. Das, for this nice summary. One of the questions I had when I was looking at the systemic reactions, particularly related to fever, I was seeing some really higher fevers on day 4 and day 5. And then you were talking about children who were PCR positive with the first dose. What kind of inclusion criteria did you have related to respiratory infections?
So yes, so I can put up the fever slide again. Apologies, let me put this up. Okay, so this is a 2 to 5 year old fever slide. And as you can see here, the top is the vaccine, the bottom is the saline placebo, and we see most of the fever being on day 1 or day 2. And then the hash is the greater than 39 here. So beyond day 1 or day 2, there were some there were some in the hash greater than 39, but it was fairly rare after day 1 or day 2. For the inclusion-exclusion criteria for the study, they did not, the children were not supposed to be acutely febrile when they were in the study, but if they had like cold symptoms or something, they were allowed to be in the study. And they just could not have been SARS-CoV-2 positive or like known SARS-CoV-2 positive in the past 14 days for study entry.
Thank you.
Thank you. Dr. Paley?
So thank you again. I have 2 questions. One is we understand that the goal was to vaccinate within 4 weeks. And could you share the extent, what the range was and or what percentage of them would have been vaccinated more than 8 weeks apart? And the second is, can you please clarify what percentage of children had underlying conditions? Thank you.
Okay, yes. So our investigators and our study parents were incredibly compliant. I think it was over 90% vaccinated right within 4 weeks. There wasn't enough variability to really warrant analyses of like significantly longer ranges. And then, Dr. Paley, you had a second question, and I'm sorry, I forget.
What was the underlying conditions that were included in some examples?
So the underlying medical conditions, I do have a slide on that one. okay, maybe we didn't pull this slide, but so we had, obesity of about like 15 to 20%. We had asthma or chronic lung disease for about 5% or so. It was a fairly representative population, seasonal allergies. This was a fairly representative population of what a general pediatrics population would be. We did exclude more severe immunosuppressing conditions, and well-controlled HIV was allowed, but I think we only had 2 or 3 children with HIV in the study.
Thank you. Dr. Daly?
Yeah, thanks so much. I'm going to continue along with this sort of line of questions, which is what proportion of the safety data set were seropositive at baseline? And then there's a follow-on question, which is, did the reactogenicity, particularly systemic reactogenicity, including fever, differ among those who were seropositive and seronegative at baseline?
Yes. So for both age groups, we had a baseline 6 to 8% seropositivity. And we've analyzed this carefully by baseline seropositivity for all of our age groups. There's a preview to our presentation next week. We did notice some increased systemic reactogenicity in the older children, so 6 to 11, and in the adolescents. But it was, they looked more like post-dose 2 after dose 1, and then their post-dose 2 was not any different. For these youngest children, and I do have that slide, for these youngest children, fever, I meant to share, but I didn't actually. Here. For these youngest children, it was really only fever that was different. So post-dose 1, the blue is the baseline seropositive, and the black is the baseline seronegative. We saw a bit more fever after dose 1. After dose 2, it evened out. For the younger, this is for 2 to 5, and then for the younger children, we saw kind of the same thing. There was a bit more fever, but the rest of the solicited adverse reactions were not different.
Great, thanks so much. And I have Dr. Lee, while I've got the floor, can I ask 2 follow-up questions?
Go ahead.
Great. So, Dr. Das, for fever, do you know if any of the children who experienced fever sought emergency department care or were hospitalized for that fever or had sort of workups for that fever?
Oh, there was the one child who had the temperature of 103, who had an ED visit for the fever, and then it was an unwitnessed seizure, but it was assumed to be a seizure based on some decreased responsiveness. That child was taken to the ED, observed, and discharged. There was no other reports of ED visits or hospitalizations related to fever in the study.
Okay, great. Thanks so much. And then one last quick question, and then I'm done. That question is, I understand that you are studying boosters in this age group. When would data on safety and immunogenicity of boosters be available for this age group? Over.
Yes. So as as we've gotten the authorization by the protocol, the study unblinds now. And so we have a rollover study starting next week, where we will provide the Omicron-containing booster to the under 6-year-olds in the study. And so that booster portion, it'll depend on how quickly they enroll. We think it'll be very quick, and we are hoping, so then we'll get to day 28, and then the time it takes us for testing. So we hope by early fall, we'll be able to bring forward the booster immunogenicity and safety data for this age group.
And just to clarify, what would be the interval between dose 2 and the booster dose?
we've discussed this interval quite a bit. When we boosted adolescents and we boosted 6 to 12 in the study. And so when we started this, we started the boosting at 5 months, which is congruent with the adult boosting. Now, I think it's kind of hard to understand, is it waning immunity or is it Omicron that is kind of driving the need for boosters? And so, we have safety data from adults for boosting at a minimum of 3 months. And so we are going to boost 3 months or more after the primary series.
Thank you. Back to Dr. Sanchez.
Again, thank you again. You mentioned a couple times that some of the fever and adverse effects could be attributed to concurrent viral infections. And was that verified, or was that because, were you able to document some adenovirus or RSV or something else to back up that statement?
Yeah, so there were 6 of those cases where there were the concurrent symptoms, but this is based on the concurrent symptoms that are reported by the PI. I don't think we had like an alternate virologic call.
And one more question. Any of these these children, particularly the younger age group, were they preterm? Had they been born prematurely?
Yes, I believe we had 37 weeks and up was our gestational age criteria, but I'm going to confirm with our. Okay, yeah, they could be more preterm if they were over 1 year of age, and so we did not have any 37 weeks and up was considered term, and then they had to be the preterm infants had to be at least 1 year to be in the study. So we did not directly have preterm infants in the youngest cohort.
And is there any plans to look at the extremely premature infants in terms of their dosing? We dose other vaccines at a chronologic age, but are there any plans to look at the 24 to 36 weekers at a chronologic age of 6 months?
No, that's a very good question. And as a pediatrician, that's also near and dear to my heart. So we are going to be starting a study in even younger infants that we're going to call Baby Cove. And we're under discussions now for the greater allowance of prematurity in that study.
Great, thank you. Very much needed.
Absolutely.
Dr. Lehr.
Thank you very much, Dr. Doss, for your presentation. Could you go to slide 5, please? I'm wondering how organization, pharmaceutical company decides on dosing. And you look like you did the dosing, compared 2 doses for toddlers or for young children, but not for infants and toddlers. I'm just wondering how you made that decision. Thank you.
Yes, so you're absolutely right. We did the 25 micrograms and the 50 microgram dose. We looked, and then we had the, and so when we saw that there was a bit more reactogenicity for the 50 micrograms, we did not pursue the 50 micrograms in the youngest children. But after we enrolled all the youngest children at the 25 microgram dose, we looked at the immunogenicity from part 1, and we saw that the immunogenicity actually looked like it would meet the pre-specified immunobridging criteria, but there was not necessarily a lot of room to go down. And the tolerability profile for the 25 micrograms in the 6 to 23 months actually looked quite good. And therefore, we chose not to look at an even lower dose in the 6 to 23-month-old group.
Thank you.
Thank you, Dr. Brooks.
Yes, thank you, Dr. Doss, for the presentation. I have 2 questions. One is, you stated there were no myocarditis cases found. Did you give the parents any specific symptoms to monitor, as myocarditis would present differently especially the 6 month, the 23 months, and even the 2 to 5 year olds? So how did you determine there was no myocarditis?
Yeah, no, that's a very good question. We talked so when the myocarditis signal was identified, we updated all of our informed consents across our whole adult and pediatric program. We did a training with our investigators, and we actually started to ask about any myocarditis symptoms in our routine unsolicited AE phone calls. And so we developed a script and we asked about all of the CDC components of the definition with the parents. And so, for the adolescents and the 6 to 12 and the 2 to 5, I think those symptoms would have been more directly reported, as you said. For the youngest children, I think it did get more challenging. And this is, we did educate the investigators that, symptoms of myocarditis present differently in this youngest age group and what those symptoms were. It's tough, I think, in general for myocarditis in the youngest age group because the symptoms are fairly non-specific. And so a lot of it does overlap with the reactogenicity symptoms that we were soliciting for. So we told the parents that if something, or the investigators, that if something is lasting particularly long or looks unusual, please bring the children in for evaluations. For all around, if there was any suspicion for myocarditis, we asked the PIs to bring the children in for evaluation.
All right, thank you. And my second question is related to immunogenicity. Since you had this serum, did you do any T-cell studies to see if there was any cellular immunity that you could measure in terms of a positive response?
Yeah, so we have the blood collected for actually all of the age groups. The cohorts are small because of the blood volumes that are required, but we have analysis plans, and hopefully we can bring the T-cell analysis forward that can, kind of ensure that directionally it's similar to what has been seen in adults. We hope in the next quarter to bring that forward.
All right, thank you.
Thank you, Dr. Daly.
Yeah, Dr. Das, I want to follow up on a comment that you just made about dose in the 6 to 23 month olds. I mean, acknowledging that finding the dose it's a balance between immunogenicity and reactogenicity, and I recognize that. And also there's immunization delivery implications. But you said you didn't think there was room to go down on the dose. And if you could just clarify if you meant in terms of meeting immunogenicity criteria or some other reason. Over.
Yeah, it's solely for meeting the immunogenicity criteria. As you know, we were asked to make sure, our study had that the GMR ratio had to be 0.8. And in our discussions with the FDA, the preference was that if lower doses than the adult dose, than the 100 microgram dose were being investigated, that GMR ratio should not be lower than 1. And so we were not confident about meeting that GMR of 1 if we went with a lower dose. And that's why we went with the 25 micrograms. That said, when we're doing our baby Cove study, we will be doing more kind of down dosing of the immunogenicity.
Thank you. Dr. Hogue?
Thank you, Dr. Das, for the presentation. We appreciate it. I'm wondering if you could just remind us, I'm sure many people have questions about, this is the age group where we're giving lots of routine immunizations from this age. Most of our routine immunizations, in fact, fall in the age group that you're presenting data on. Can you remind us about whether the children in this study were also during this time frame receiving their routine and recommended vaccinations, and any comment on concomitant administration of the vaccine, of your vaccine with those routine immunizations? Over.
Yeah, no, that is a very good point. We did not allow concomitant immunization for this first, for kind of this first pass study. We did ask the investigators to offset flu vaccine by 2 weeks and offset other routinely administered vaccine by 4 weeks. And so we do not have concomitant administration data yet. Fully take the point that that is an important piece, and our future studies will look at concomitant administration, both in terms of immunogenicity and reactogenicity.
Thank you. Dr. Paling.
Thank you. I've got 2 questions. One is, could you share what you learned about lymphadenitis? We do know that these vaccines are reactive and lymphadenitis is relatively common. And then the second is, on your upper age, children 5, were there any that were enrolled and by the time they got to the second dose were eligible for the next dose up? Thank you.
Yep, so I will take your second question first. So we did not adjust the dose. I know the age cutoff can kind of be arbitrary, but our investigators followed the rule that they got whatever dose they started with. So if they started with 25 micrograms and they turned 6, they would still get a 25 microgram dose, so they would stay within the cohort. In terms of the lymphadenopathy, we did see lymphadenopathy, the incidence of lymphadenopathy in children. I believe it was a bit lower than, it was a bit lower than, I shouldn't make the statement about the comparison with adults. Actually, the number is escaping me. But for the 2 to 5 year old age group, we had that it was about post-dose 2, it was 9% in the vaccinees, but it was all grade 1 or grade 2. There was no grade 3 or grade 4 lymphadenopathy. For the youngest children, it was also, again, about 9% post-dose 2, and it was all grade 1 or grade 2.
And could I follow? Could you
Sure.
clarify the time frame of resolution?
No, I just have the data in front of me for the within 7 days. I know we did the analyses for the resolution. I don't have them at my fingertips, but I will follow up with that question.
Thank you. Dr. Brooks, you have your hands raised. I just want to make sure. Did you have another question? Okay, I'll assume not. I did want to follow up on a point, and now I can't remember which colleague of mine made the point, which is this question about concomitant vaccination. It has to do with whether or not, and perhaps it's a question for Moderna/FDA, whether or not the labeling will include information about the risk of febrile seizures, which can happen with any infection or with vaccines, and what that might look like. And then just thinking about our clinical considerations team and also the AAP and PIDS, whether or not there's any comments about at least providing information to families about the risk of febrile seizure generally and then specifically.
I can start by what is in our approved fact sheet. So in our approved fact sheet, we do have the case detailed out, the case of the febrile seizure that occurred after the first dose. I'll leave it to others to talk about the rest of the question.
Yeah, I'll defer. This is Dr. Oliver. I'll defer to Dr. Fink if he wants to comment on the EUA specifically, but I can say we have a presentation tomorrow on clinical considerations, and febrile seizures will be mentioned there, but I can save the discussion and the exact language for tomorrow.
that's absolutely fine. We can discuss it tomorrow. Thank you. Are there any other questions for Dr. Das? I don't see any additional hands raised. So as planned, we will take a break until the top of the hour, so 1 p.m. Eastern Standard, 10 a.m. Pacific Time, and we will return to hear Dr. Gruber from Pfizer. I want to thank Dr. Das for her presentation and for patiently answering all of our questions, and we'll look forward to talking to everyone very soon. Thank you.
Thank you so much.
Thank you, everyone. We're at the top of the hour, so we'll reconvene our ACIP meeting today. For the next session, we have Dr. Bill Gruber from Pfizer presenting on the safety, immunogenicity, and efficacy of BNT162b2 in children ages 6 months through 4 years of age. Dr. Gruber, the floor is yours.
Okay, thank you, Dr. Lee. Can you hear me well?
We can, thank you.
Okay, great. On behalf of Pfizer and BioNTech, it is my pleasure to share data supporting the BNT162b2 recommendations in individuals 6 months through 4 years of age. I believe the CDC is advancing my slides for me, so please, next slide. My name is Bill Gruber, and I head the Vaccine Clinical Research and Development Group at Pfizer. Next slide, please. Today's agenda covers the topics shown here with specific attention to coverage of the clinical safety, immunogenicity, and efficacy data, along with the assessment of benefit risk. Next slide, please. I'm now going to share with you the clinical data that supports recommendations for this age group. Next slide. We began in 5 to 11-year-olds before progressing to 64 participants in vulnerable 6 month through 4-year-old age group to achieve the right balance in safety profile and immune response. We found that nearly 19% of 2 to less than 5-year-olds who received 10 micrograms developed fevers after the first and second dose, and 1/3 of these fevers were severe. This could be poorly accepted by parents, reducing adherence to the primary 3-dose series. In contrast, the 3 microgram dose had a much better tolerability profile, combined with comparable to better immune responses to the SARS coronavirus 2 reference strain. Therefore, the 3 microgram dose level was advanced into phase 2/3. To infer efficacy in the pediatric population in the pivotal study, immunological non-inferiority to a 16 to 25-year-old population for whom efficacy was established was assessed in addition to safety to satisfy emergency use authorization immune response criteria and infer efficacy. Although not required for EUA approval, COVID-19 surveillance was conducted, permitting an early evaluation of vaccine efficacy. Next slide, please. Children were administered 2 doses, as shown at the top, 21 days apart, and then a 3rd dose was administered at least 60 days later. Planned follow-up for the study is as shown. Current follow-up includes 1 month post-dose 3 serology and efficacy to the data cutoff of April the 29th. Next slide, please. All safety data that I will present is in the blinded, placebo-controlled follow-up period, first for 2 to less than 4-year-olds, and then the 6 months to less than 2-year-olds. Next slide. Demographics in the 2 to less than 5-year-old age group are balanced between vaccine and placebo groups, whether gender, race, ethnicity, SARS coronavirus 2 exposure, or comorbidities. Next slide, please. Local reactions captured by eDiary over 7 days were mostly mild to moderate in severity, somewhat higher in the vaccine recipients compared to placebo recipients, and did not show an increase from dose 2 to dose 3. Local reactions were higher or similar in frequency and severity in those with evidence of prior SARS coronavirus 2 infection at baseline, and all within a well-tolerated range. There were no grade 4 local reactions. Next slide, please. Systemic symptoms solicited by electronic diary were mostly mild to moderate and comparable after each dose. Fever, fatigue, or other symptom rates were remarkably similar to those seen in placebo recipients at each of the 3 doses, and much lower than those in older age groups immunized with higher dose levels. Fever rates are comparable or lower than other childhood vaccines. Only 3 or less than 0.2% of BNT162b2 participants reported fever greater than 40 degrees centigrade after dose 1 or 2, starting on day 2, day 4, or day 6, with all returning to normal 6 to 7 days after the dose, one of whom had a presentation suggestive of a viral exanthem. None of these required hospitalization, and all resolved quickly. Systemic symptoms were higher or similar in frequency and severity in those with evidence of prior SARS coronavirus 2 infection at baseline, and all within a well-tolerated range. This highly favorable tolerability profile for the Pfizer-BioNTech vaccine should be reassuring to parents and care providers. Next slide, please. In the 2 to less than 5-year-old age group, blinded safety follow-up occurred from the time of dose 2 to dose 3 or cutoff date for a median of 4.0 months, and for dose 3 to the cutoff date for a median of 1.4 months. Next slide, please. Overall, unsolicited adverse events, related adverse events, SAEs, withdrawals were infrequent and comparable between vaccine and placebo groups. 3 subjects, or 0.2%, in the vaccine group withdrew from the study due to adverse events, pyrexia, considered related, status epilepticus, considered unrelated, and urticaria, considered unrelated. 1 participant in the placebo group withdrew due to facial swelling and rash, considered related. There were no deaths reported in this age group. AEs, as defined by system organ class, were comparable between vaccine and placebo groups. Next slide, please. Now, let's look at the 6-month to less than 2-year-olds. The demographics again show balance between the vaccine and placebo groups related to gender, race, or ethnicity, prior SARS coronavirus 2 infection, and comorbidity. Next slide, please. Local reactions in the 6-month to less than 2-year-old group with and without prior SARS coronavirus 2 infection were mild to moderate, with incidence somewhat higher in vaccine recipients. Local reactions were somewhat higher or similar in frequency and severity in those with evidence of prior SARS coronavirus 2 infection at baseline, and all within a well-tolerated range. There were no grade 4 events, and frequency remained relatively the same after each dose, consistent with a very well-tolerated vaccine. Next slide, please. Fever, decreased appetite, drowsiness, and irritability were mostly mild to moderate and similar to placebo rates, lower than those observed in older children and adults, and comparable to those after other childhood vaccines. Fever greater than 40 degrees centigrade was reported by only 3 vaccine recipients, or less than 0.1% for each dose, starting on day 1, day 2, or day 3, with all returning to normal 5 to 6 days after the dose, 2 of whom had a concurrent viral infection. 1 fever greater than 40 degrees centigrade was reported by a placebo recipient after the first dose. None of these required hospitalization, and all resolved quickly. The systemic symptoms were somewhat higher or similar in frequency and severity in those with evidence of prior SARS coronavirus 2 infection at baseline, and all within a well-tolerated range. Again, the overall incidence and low severity of systemic symptoms speaks to a favorable tolerability profile that should be reassuring to parents and care providers. Next slide, please. Safety follow-up included blinded follow-up from the time of dose 2 to dose 3, or the cutoff date for a median of 6.3 months, and from dose 3 to the cutoff date for a median of 1.3 months. Next slide, please. Any adverse events, related adverse events, SAEs, withdrawals were infrequent and comparable between vaccine and placebo groups. 3 participants, 0.3% in the BNT162b2 group, withdrew from the study due to adverse events, all related. 2 due to fever greater than 40 degrees Celsius, 1 of which had a viral exansum that was unrelated. 1 participant withdrew to a generalized rash on the face and trunk. There were no deaths reported in this age group. AEs, as defined by system organ class, were comparable between vaccine and placebo recipients. Next slide, please. Few adverse events of special interest were recorded. Predominant categories were potential angioedema and hypersensitivity, comprising mainly urticarias and rashes, balanced between groups. No CDC-defined adverse events of special interest were observed. Next slide, please. The carefully selected dose level of 3 micrograms for the BNT162b2 vaccine was shown to have a favorable safety profile and was well tolerated in infants, toddlers, and very young children. Vaccine reactions were mostly mild to moderate and short-lived, with systemic reactions comparable to placebo. Reactions were comparable after dose 1, 2, and 3. The unsolicited adverse event profile mostly reflected reactogenicity or common childhood illness. Favorable safety profile should encourage vaccine adherence for each of the 3 doses. Next slide, please. Demonstration of non-inferior immune response in children less than 5 years of age compared to immune response in 16 to 25-year-olds after 2 doses was judged by the FDA as sufficient to meet immunologic success criteria for emergency use authorization. Next slide, please. Immunobridging criteria for 2 to less than 5 years of age were not met for geometric mean ratio, but were met for seroresponse after dose 2. Geometric mean neutralization titers are shown for 2 to less than 5-year-olds, light blue, compared to those in 16 to 25-year-olds, dark blue, after dose 2 at the top of the slide. I draw your attention to the GMR in the tan box at the top of 0.61, which failed to meet the lower confidence bound of 0.67. However, the difference in seroresponse in these groups shown at the bottom right of minus 0.9% and 95% lower bound of minus 4.3% are above the minus 10% criteria. Success was not declared due to not meeting the GMR criterion. Next slide, please. However, in consultation with the FDA, a similar comparison was made between GMTs and the 2 to less than 5-year-olds to greater than or equal to 65-year-olds in the pivotal efficacy trial. In this case, the GMR was 1.92 with a lower bound of 1.56, well above the 0.67 non-inferiority criteria. Although this was a post hoc analysis, vaccine efficacy in the greater than or equal to 65-year-olds was 94.5%. So a non-inferior immune response seen in the 2 to less than 5-year-olds is likely to predict efficacy. As you will see, 35.9% efficacy in this age group was observed in 2 to less than 5-year-olds after the second dose. Despite the likely benefit of a level of 35.9% efficacy after dose 2, based on the growing importance of Omicron, we judged a 3-dose series as important to provide improved protection, just as is required for every other age group. Next slide, please. Immunobridging criteria of 6 months to less than 2-year-olds compared to 16 to 25 years of age were both met. Immunobridging criteria were met for both the geometric mean ratio, shown 1.03, lower bound of 0.9, above 0.67, and difference in seroresponse at 1.7%, well above the minus 10% criterion. But again, based on observed efficacy data I will share shortly, we judged that just as for every other age group, in an Omicron predominant environment, a 3-dose series would prove necessary for a high level of protection. Next slide, please. Immunobridging criteria in the 2 to less than 5-year-olds were met for both GMR and seroresponse, comparing post-dose 3 responses to post-dose 2 responses in 16 to 25-year-olds, which infers vaccine effectiveness after dose 3 in this age group. The median dosing time between dose 2 and dose 3 was 10.7 weeks. The geometric mean ratio observed was 1.30, lower bound of 1.13, well above the 0.67 success criteria. Likewise, difference in seroresponse was 1.2%, lower bound of minus 1.5%, well above the minus 10% non-inferiority success criteria. Next slide, please. Now, let's look at the 6 month to less than 2-year-olds. Immunobridging criteria were met for both GMR and seroresponse, again inferring vaccine effectiveness in this age group. The median dosing time between dose 2 and dose 3 was 12.9 weeks. GMR was 1.19 with a lower bound of 1, well above the 0.67 required success criteria. Difference in seroresponse was 1.2% with a lower bound of minus 3.4, again well above the minus 10% required success criteria. So for both younger children as well as the older children, immunobridging criteria were met, inferring vaccine effectiveness. Next slide, please. Given that most current COVID-19 cases are caused by Omicron, we also evaluate the ability of 2 and 3 dose immune sera from 6 months to less than 5-year-olds to neutralize Omicron compared to sera from adults. In this graph, the older comparator group is a 24 to 74-year-old adult sentinel cohort from the licensure trial. Immune responses to Omicron, shown in pink, were compared to those of the reference vaccine strain, shown in blue using a plaque reduction neutralization assay. DMTs are shown on the y-axis and age groups are shown left to right. As you can see, we see comparable immune responses across all three age groups to the reference strain and Omicron. However, as reported by several groups, Omicron responses after only 2 doses are low and uniformly so across the pediatric and adult age groups. Low Omicron neutralization titers after 2 doses seem to correlate with lower efficacy against 2 vaccine doses for Omicron. Next slide, please. However, this picture changes when serum samples after 3 doses are being evaluated. In this data set, an adult comparator group was used that received the 3rd dose at a similar time interval after the 2nd dose as the pediatric group at about 11 to 13 weeks. Neutralizing antibody responses were measured using a fluorescent focused neutralization assay. Left to right, for 6 months to less than 2-year-olds and 2 to less than 5-year-olds, the Omicron-specific neutralization titers after 3 doses are far higher than those on the prior slide after 2 doses, and the Omicron-specific titers are very similar across age groups. Most importantly, the pediatric group titers are essentially the same as in the adult group, predicting that similar efficacy as shown in adults could likely be observed for the 6 months to less than 5-year-old age group after dose 3. I will shortly share with you descriptive data showing observed post-dose 3 efficacy matching this prediction. Next slide, please. So here are the immunogenicity conclusion in 6 months to less than 5-year-olds. Immunobridging criteria were partially met after dose 2. All immunobridging criteria post-dose 3 in young children required for an emergency use authorization were met for both age groups, inferring effectiveness. Omicron neutralization titers were low after 2 doses for pediatric and adult cohorts, but increased substantially after a 3rd dose in the 6 months to less than 5-year-olds to similar levels observed in adults. Thus, as has been observed in other populations, a 3rd dose is required also for the 6 months to less than 5-year-old age group to ensure a more robust protection against COVID-19 due to Omicron than can be achieved after 2 doses, and despite the fact that we saw some level of efficacy after a 2nd dose. Next slide, please. So what have we learned from the adult and pediatric experience about the potential vaccine efficacy against COVID-19? Next slide, please. Here's a summary of descriptive observed efficacy in the blinded follow-up period. Efficacy against the Delta variant is shown in blue, and efficacy against the Omicron variant is shown in pink. The Delta surge ended prior to the 3rd dose, so no children were exposed to Delta after the 3rd dose, marked as NA. Observed efficacy against Delta post-dose 2 is favorable across all age groups post-dose 2. The emergence of Omicron presented a new challenge. Shown in pink on the left, you can see that for children 6 months to less than 5 years of age post-dose 2, efficacy was 21.8% in the 6 month to less than 5-year-old age group, and correspondingly as shown for the other subgroups. This is consistent with the poor antibody response after the 2nd dose. Now look what happens after the 3rd dose. Cases post-dose 3 in this clinical study were confirmed to be Omicron. Efficacy rises to 80.3% overall and correspondingly high for the respective age groups. This is consistent with the higher antibody response seen after the 3rd dose against Omicron, like that of older children and adults, and consistent with corresponding higher efficacy in older children and adults after a 3rd dose against Omicron. Next slide, please. Overall, vaccine efficacy observed over the period of blinded observation after dose 2 is shown here. Looking at the 2 to less than 5-year-old age group in the middle, 35.9% and 34.3% benefit for a valuable population was shown. This indicates likely benefit after the 2nd dose for at least children 2 to less than 5 years of age. Next slide, please. Note cases in placebo recipients in red and in in red and vaccine recipients in blue on this plot. For 2 to less than 5-year-olds, there appears to be increasing efficacy over 210 days, and the interval is important, of observation after dose 1, largely driven by the efficacy after the second dose, since cases after the third dose represent a small minority of total cases. This supports a likely benefit after the second dose in this age group. Next slide, please. The potential benefit of the second dose is not as readily apparent in 6 months to less than 2-year-olds, but perhaps there is some separation of the curve at some distance from the second dose, shown on the right, suggesting the possibility of maturation of response and protection. The goal of the third dose is to shift that widening of the curve to the left. Next slide, please. Some vaccine effectiveness after dose 2 is likely to be inferred by the observed 35% efficacy in at least 2 to less than 5-year-olds. However, the immune response data shared with you today, descriptive efficacy shown on the right, and the experience in older children and adults supports the following. 3 doses of the BNT162b2 vaccine are in the best interest of children to provide a high level of protection against Omicron, observed to be 80.3% with lower bound of 95% confidence interval of 13.9 in 6 months to less than 5-year-olds with point estimates in smaller subgroups as shown. So next slide, please. So what can we conclude about efficacy? As demonstrated in other pediatric and adult age groups, 2 doses of BNT162b2 are protective against variants of concern such as Delta, but do not provide adequate protection against Omicron. As demonstrated in other pediatric and adult age groups, a third dose is necessary to provide high protection against Omicron. Next slide, please. Ongoing pharmacoepidemiology, including 5 pediatric studies, as well as proactive risk mitigation and pharmacovigilance, will be extended to this younger age group. Next slide, please. The potential benefits of vaccinating children 6 months to less than 5 years of age outweigh the known potential risks. This age group of 6 months to less than 5 years of age is currently unprotected. Protection against COVID-19 is critical, particularly in light of the unpredictability of potential new waves and emergence of new variants of concern. Available safety, immunogenicity, and efficacy information support a highly favorable benefit-risk profile for administration of 3 doses of BNT162b2 at 3 micrograms to children less than 5 years of age. Next slide, please. Pfizer and BioNTech wish to thank all those listed who made this investigation possible, and I and my Pfizer colleagues will now be happy to entertain questions. Thank you.
This presentation is open for questions. Dr. Long.
Hi, thanks, Dr. Gruber. Can you go back to slide 30? And I'm sure you said this early in the presentation, but I just want to be sure I understand showing this efficacy after the third dose. What is the definition of the clinical problem that you're protecting against? Is it infection? Is it
so it's symptomatic illness with at least one symptom.
One symptom. So it's the CDC definition. Okay. And then, yes, go ahead.
No, I was just saying it's close to that. That's correct.
Okay. And then I didn't write down the number, but the slide that shows it's the Kaplan-Meier plot of cumulative something over time in older people after 3.
That's probably slide 32 in the 2 less than 5-year-olds. Maybe.
Yes, I think it was very close. Yes. So, and this was an assumption slide trying to show that there was efficacy from a third dose, that these people likely received a third dose.
Yeah, so I think, let me see if I can explain this slide in a little bit more detail. So yes. In the interest of time for the overall presentation, I didn't get a chance to really describe all the details here. But what you see on the x-axis is the timing from dose 1. So this includes, of course, children who have had now dose 2, and you can anticipate if I put a line there, it'd be at about day 21 for dose 2.
Okay.
So you can see, and then dose 3 was basically, as I told you, about 11 weeks or so out from the time of dose 2. So you can, and remembering that the total number of cases that we had in this age group post-dose 3 were 7. So the fact is that most of the cases that you're seeing here are actually still post-dose 2. And that, I think, that what drives the conclusion and the estimate of around 35% or efficacy or so is the fact that most of the efficacy you're seeing here is driven post-dose 2. And then, of course, I share with you the table that speaks to the post-dose 3 efficacy, which is specifically focused on looking after dose 3, if that helps.
Yes, I was really pretty interested in time since any dose. So it looks like you would just estimate that there was 100 days, at least 3 months after the last immunization that anybody could get here. And there was still
I think it was encouraging to us. And again, this could be well due to some maturation of immune response. Obviously, there are contending forces at play. We know that essentially everybody, particularly after 2 doses, shows waning protection against symptomatic disease, less so against severe disease, and that protection is more sustained after a 3rd dose. But this would suggest, if you look, and again, I don't want to make too much of the curve because the numbers start becoming smaller, farther out you go, but you do get some impression that maybe there's even some widening here. And I think it's important, and I think you'll see this in the CDC slides that we've had a chance to take a look at, that it's a little dangerous to compare efficacy against, across, different studies with different follow-up. But I do think the follow-up here out to 210 days is particularly important because it does suggest that, at least in this age group, there may be some persistence of protection. And of course, our goal is not to have children wait out to 210 days. Our data would support giving that 3rd dose so we can boost that efficacy up to 80% or more.
Thank you. And the very last thing is, I assume that this is by definition of 1 symptom and positive PCR.
Yes. These are nucleic acid amplification tests, either based on a central lab test or an approved test from a local laboratory, but it had to, we had to meet specific predefined requirements for that to be acceptable. So this was not home testing. This was all laboratory testing.
Thank you.
Thank you, Dr. Paling.
Okay, I have 2 questions. First is, could you remind us what the placebo is?
Paling.
Perfect. And then the second thing is, how much difference in timing between the 1st and 2nd dose did you have? Did they all cluster right at 21 weeks, or do you have some experience about spreading the doses between dose 1 and 2?
So I think in this particular study, I don't know, we have a slide that represents, but I think like all our other studies, it's very, very highly clustered between the 1st and 2nd dose at around 21 days. And then, as I explained, after the 3rd dose, the range is close to about 11 to 13 weeks, 2nd to 3rd dose.
And we do have a slide, Dr. Gruber, it's Charu, if we want to pull up slide 62, if that would help.
I'll leave it to Dr. Paling. Do you want us to pull up the slide?
Thank you.
Yeah. All right. So let's see if it's slide 62, if we want to pull that up.
We see it. Thank you.
This is the dosing again between dose 2 and dose 3. I think Dr. Paling was asking between dose 1 and dose 2. And again, I think 90-something% of my recollection, as with all our other studies, is in the between dose 1 and dose 2 occurred within the 21-day period.
It was 99%. Thanks.
99%. There you go. Even higher.
Thank you. Ms. Bata?
Thank you, Dr. Kruger, for this brief summary. I appreciate it. Just in looking at the 6 months to under 5, slide number 34, it looks like there's there are very wide confidence intervals, and in each of the subgroups, they're below, they cross 0. These were cases that were observed after February 7th until what point in time?
Up until the data cutoff. And so there are actually 2 lines of evidence that indicate that these are all Omicron cases. One is the timing, so they were all after actually February 7th, but also based on sequencing, they're confirmed to be Omicron. Let me just comment about the confidence intervals. We recognize, obviously, the 6 months to less than 2-year-olds, you're talking about 3 cases here. And I think the argument we're making is that overall, when you roll this up, the findings are consistent with what we see in other populations. I think it's important also to keep in mind that, we think about our other age groups, 5 to 11, 12 to 17, for which we provided in the past, or I'm sorry, 12 to 15, for which we provided data in the past. The total numbers of subjects were not much bigger than what we have here. And what we didn't do at that time, nor were we required to do, was sort of break it down by smaller intervals. So when you talk about the 6 months to less than 2-year-olds, that's obviously a smaller proportion of the population. There are fewer total children that were sort of recruited there. And you can see the denominators as shown there. In a smaller age segment who may or may not have, equivalent exposure, perhaps are in a more protected state. So again, we actually look back, I don't think we have the slide in this set, but we actually look back. If we were asked, for instance, to look, in 2-year intervals between the 5 to 11-year-olds, we would have found some for which the lower confidence interval was below 0. And yet it was the nature of the overall span of 5 to 11s that provided enough cases to be, confident that in that age group, given the immune response as being comparable to what was seen in other populations, that they would likely be protected. So, I'm not dismissing by any means that, okay, the number are fairly small, but I would put this in the context for the 6 months to less than 2-year-olds of what you've seen in other populations, the immune response that matches up in terms of non-inferiority, and the high efficacy that's seen in other populations in this range where that type of antibody response has been achieved.
And I really appreciate the fact that these numbers are small. Are you planning to continue to assess the vaccine efficacy as time plots out? Because I think you'll get bigger numbers and more certain.
Yeah. So it's a very important and great question. There are 2 ways, obviously, we're going to do this. We have the capacity, obviously, up until the point that we start rolling individuals over who are all getting vaccine, which we'll have some obligation to do within the clinical trial. And in fact, already are doing this at 6 months after individuals have been randomized. But we will have additional cases under a blinded placebo-controlled period that should give us more precision on these numbers. And of course, after licensure, just as we always do, we'll be taking advantage of the Kaiser Permanente population that served us so well in the past to better identify true effectiveness. And of course, it will give us the long-term benefits as well of durability, of protection, not only against milder disease, but severe disease. And I might add, I think there's great comfort that we have had that it does appear to be the case in older populations that protection against severe disease leading to significant medical attention or particularly hospitalization seems to be better preserved. And given that the antibody responses are well matched here and the vaccine efficacy that we're seeing is already high after a 3rd dose, it gives me real confidence that we should see the same thing in this population, but we'll definitely study it.
Thank you.
Thank you. Dr. Sanchez.
Thank you. And thank you, Dr. Gruber. And I'm going to be asking similar questions than with the previous talk as well. Where was the vaccine administered in these children? Was it either the arm or the eye?
Yeah, so there were instructions given to the investigators, consonant with other instructions for pediatric vaccines, that children less than 2-year-olds would have it administered in the thigh, and children over 2 years of age were to have it administered in the arm.
And along with that, when you reported the swelling as an adverse effect, was that local swelling at the site, or were you talking more about adenopathy and in the older children, inguinal swelling and adenopathy?
Yeah, this was local swelling. I will say, and we actually have a slide with this that was presented at the VRPAC where we talked about the system organ class comparisons, that lymphadenopathy was extremely infrequent, less than we'd seen in other populations in both age groups. So, from that perspective, it seems that we're seeing less of that manifestation of vaccination.
And how about the prematurity issue? Were any of these?
This is the advantage of having had a chance to listen to Moderna's talk. So we looked that up real quick, and 1.6%. I don't know that we have immune response data. I think we also are obviously looking as to what the future course will be to investigate vaccine in children less than 6 months of age, where I think we'll have a better opportunity to identify potential implications of prematurity as we get into that younger age group. And we're in discussions with FDA about how best to do that.
And how about concomitant vaccines? I'm sorry, Dr. Lee, I hope this is okay.
No, please go ahead, Matt.
Yeah. So concomitant vaccine use, again, was a temporary exclusion for inactivated vaccines and rotavirus 2 weeks before or 2 weeks after. For other live virus vaccines, it was 4 weeks. And so we don't have concomitant vaccine data when the vaccines were administered at the same time. Obviously, that becomes that much more important within the crowded vaccine schedule, for which you have more limitations as we work to look at children less than 6 months of age, and we're clearly going to have to think about that there.
And then finally, it doesn't seem, and just correct me, that you did not do any surveillance for positive PCR, so we don't know about asymptomatic infection or transmission.
Yeah, we did not do routine surveillance in this population to look at impacts on transmission. I think that's going to, await real-world effectiveness studies, which I think have been useful in identifying potential for protection against transmission.
Thank you.
Thank you, Dr. Bell.
Thank you, and thank you very much for the presentation. I also appreciate the efforts to evaluate efficacy, which I know is difficult, obviously, in this situation. And with that in mind, it makes the immunologic data that much more important. We're really relying on immunobridging. And so I got a little bit confused as you were showing the immune response with the comparison populations. It seemed like sometimes it was adolescents, sometimes it was young adults, sometimes it was people older than 65. Then there were other age categories. And I just wondered, as I say, I got a bit confused, and I just wondered if you could help us, if you could explain a little bit more for us what the comparison groups were in the immunobridging studies.
Yeah, so I'm happy to do that. So for the purposes of meeting emergency use authorization criteria, the population chosen to which we compared was 16 to 25-year-olds from the pivotal study. Now, why was that the case? Well, as is often the case, you want to make your comparison to a population for which you have demonstrated efficacy in a well-controlled trial. And so 16 to 25-year-olds are from that population. Now, why 16 to 25? Well, that actually provides the most rigorous comparison, because we know that the younger you were in that age group, from 16 on up to above 65, the higher the antibody response would be. So it sets the bar pretty high to be able to demonstrate non-inferiority. So having demonstrated that, you could be confident, okay, I've demonstrated it, against a pretty rigorous assessment, and therefore, I should be confident that we should see a level of efficacy, at least that of which was seen in the efficacy trial for individuals that were enrolled in that trial. So that was the basis for the non-inferiority criteria, and that was true whether we were looking at 2 doses in the pediatric population under study or 3 doses. We were comparing to 2 doses in the 16 to 25-year-olds because that translated directly to the pivotal efficacy trial, and it was agreed upon by the FDA as then inferring effectiveness. Then in addition to that, to further inform our thinking about, okay, but the world has changed. The world has changed where we're now encountering Omicron and its descendants as the major threat. And we all have now seen that 2 doses of the vaccine just don't work as well against Omicron. And that was, again, affecting our thinking, in the context of thinking about what the future should be. We wanted a vaccine that could protect well against Omicron, not just at a 35% level, but at a high level, 40%. 30% offers some benefit, but the goal here is to try to prevent Omicron as best one can. So in that context, we then did comparisons of post-dose 3 to post-dose 3, the younger population to the older population, and showed that post-dose 3, we were matching. If you go, actually, we can go to slide 27, because I think this is a fundamental slide to understand this. So you can see here that the goal was really after dose 3 to show, can we achieve antibody levels comparable to an adult population for which we know we've been able to demonstrate efficacy, and for which 3 doses of vaccine from real-world effectiveness data is showing efficacy that's relatively high in the 70, 80+% range. And so you can see that, given the limitations of the sample size, you have overlapping confidence intervals. You see, 139 for the 12 to point. I'm sorry, for the 6 month and less than 2-year-olds, 113 for the 2 to less than 5, and 155 for the 18 to 50-year-olds. So this, combined with the descriptive efficacy, says this is on the right track. We have every confidence that we're going to see high efficacy against Omicron. Hopefully that explains.
Thank you. Dr. Lee, could I just ask a follow-up question, please?
Please do.
Could we go to slide 22, please? So this was what started my confusion. And just to ask you a little bit more, what the thinking was about using a greater than 65-year-old comparison population. I recognize this is only after dose 2, and it's a small slice of the overall picture. But nonetheless, I just got a bit confused. Thank you. Yeah.
So this was, again, I want to emphasize, this was a post hoc analysis. So back in February, when we were first greeted with the information that I've shared with you, and Omicron was really taking hold, and we were trying to assess, okay, what is in the best interest of children? We said, well, look, the individuals over than 65 years of age, it isn't as if they had no efficacy. They had quite a high degree of efficacy. So arguably, could one have chosen this as a comparison group of non-inferiority? And how would we have fared in that circumstance? And so we did that in consultation with the FDA and demonstrated that, yes, if we made that comparison, not only would we have passed, you can see that the lower confidence interval suggests that we're well above. With at 1.56 geometric mean ratio, if you see there on the right-hand side, we're well above the criteria of 0.67 that would be required if we made that comparison. So if the goal was really to compare to a population with efficacy, we would have passed at that point, suggesting, okay, there probably is some likelihood of benefit. And in fact, for the 2 to less than 5-year-olds, looking back as we just shared with Dr. Long and showed during the core presentation, you can see efficacy in that age group. So this was just another measure to give us some sense of where we were. But I want to emphasize that we considered that 35% or slightly higher efficacy was just not enough for us to, be confident that we were doing right by children and why we needed a third dose. 2 doses could offer some potential benefit, but the goal here is to get to a high level of efficacy and get children vaccinated as quickly as we can.
Thank you. Dr. Daly, do you have a follow-up question to this? Because I actually wanted to ask a clarifying question on this thread.
Why don't you jump in, Dr. Lee?
Okay, thank you. If we could go to slide, I just want to confirm that I understand the data. I'm actually going to ask you to run through a couple of slides for me because I'm also confused. So on slide 22, that's where we were. If you go to slide 21, so this is post-dose 2, the neutralization NT50 titers, post-dose 2 in the original population that was per protocol. Is that right?
Right, that's correct.
Okay. And then the sort of post-hoc analysis is what you showed, the comparison to the older adults, which we understand that they probably did not have as great immunogenicity on slide 22, sorry.
22, right.
Okay. And then in slide 23, I think what you're saying is that when you did that comparison, you didn't see that low GMR as you did for the younger kids. So it looked equivalent following 2 doses for each.
Well, yeah, so let me be clear about this slide to make sure we're all talking about the same thing. So this isn't the 6 months to less than 2-year-olds.
Yes.
So back in February, when we had this data, we had met the non-inferiority criteria. And ostensibly, we could have proceeded to potentially say, okay, we met non-inferiority in this age group. Based on that inferring efficacy, we could proceed. But again, the conscious decision was made based on the efficacy that we were seeing in Omicron in both age groups, that it was in the best interest of children to wait until we had the 3rd dose data and we could show, convincing high level of efficacy.
Okay.
And that was, and we had to wait for that 3rd dose. Children were just starting to get dosed in January with that 3rd dose.
Okay, thank you. Yes, I got the age groups confused. So the younger groups were okay, at least they seemed equivalent post-dose 2. The older groups looked lower compared to the original population.
I mean, if you don't mind, if we go back to 21, because I just want to clarify, again, it wasn't, we passed one test, the seroresponse test, but we didn't pass the geometric mean ratio. And so, the criteria was we really needed to pass both.
Yeah.
But there was some suggestion. And again, I think given, let's face it, given what we've now seen in terms of efficacy, one can argue that this is not as precise a measure of what you're likely to see. And hence the reason why it made some sense to say, well, look, there's some evidence here that based on seroresponse, we might have efficacy. Let's look at the older population as a comparator and see if that, would have been a better predictor. And in fact, in retrospect, it probably is, in this context.
Okay, thank you. And then if you go to slide 24, then this is post-dose 3 of the 2 to less than 5 compared to post-dose 2 of the 16 to 25. So it, in a way, it looks a little higher, but essentially equivalent to. So I'm just trying to understand. So I'm thinking my interpretation of this is that 3 doses is as good as 2 doses in the 16 to 25-year-old population here.
Yeah, well, statistically speaking, you can see that the lower bound is actually above 1. So you could argue that the geometric mean titer is, statistically actually higher than it is in the 16 to 25-year-olds after a 3rd dose in the 2 to less than 5-year-olds compared to, after a 2nd dose in the 16 to 25. So it certainly meets the non-inferiority criteria and is actually a little bit greater. And if you don't mind, we can go and just, speak to the same thing on slide 25, which is the 6 months to less than 2-year-olds. You see the same thing, that we're right at, with the lower bound of 1. The FDA had hoped that at least the point estimate would be 1. Well, we've got the lower bound of 1. I mean, to meet the criteria, we needed to be above 0.67. The FDA said, appropriately to try to, increase the likelihood that protection would be seen, that the point estimate should be 1, but in fact, our lower bound is 1. So in both instances, we actually exceeded the criteria that was required for this comparison, and hence the reason, as you've heard today, this is part of what supported the approval for emergency use.
Okay. So I think, thank you. So basically, so the 2 doses in the younger age groups, I'm going to speak very broadly. I recognize it's really for the 2 to 5-year-olds, 2 to 4-year-olds, is lower. The immunogenicity or the GMR doesn't meet it for following dose 2, but it clearly meets it following dose 3. So that's really helpful to understand. I'm just going to say that out loud to make sure that that is correct. That's my interpretation. Does that seem right, Dr. Gruber?
Yeah. And in fact, I mean, that's, if we go again, just to maybe we can highlight it in the conclusion slide, which I think was 28 for the immunogenicity. If you wouldn't mind going to that slide. So immunobridging criteria were partially met after dose 2. And I'd say along with that, that conferred, at least in the 2 to less than 5-year-olds, some degree of efficacy that we in fact did see. Arguably, there's very little to see in the 6-month 2-year-olds, except potentially out to, distal from vaccination, which again could represent immune response. But I don't want to make too much of that given the small numbers. But clearly, after the 3rd dose, we're meeting the immunogenicity criteria. And then when you saw the descriptive efficacy, that's consistent with the older adult populations and older children.
Okay. And then to your point about efficacy being the thing that we'd actually like to achieve, the numbers are small, so the confidence intervals are quite wide in general. And then for the subgroup analysis, go below 0 because the numbers are very small.
Yeah, again, as I think with all the data that's being presented today, it's hard to have really high confidence intervals because I think everybody's struggling with getting enough cases in time. And remember that the efficacy was not a requirement for approval, right? The efficacy, because we can't predict when the epidemics will occur. I mean, as you saw, after the 3rd dose, we had no Delta, right? So there was no way to sort of look at that. But I think, looking, if you would, at slide 34, to your point, just so people can have this in front of them as we're talking about it, for the group for which we at least have numbers to have some confidence and anticipating that given the antibody response looked good in both the 6-month to less than 2-year-olds and the 2 to less than 5-year-olds, I would contend that the 6-month to less than 5-year-old efficacy, where the lower bound is above 0 at 13.9%, is likely to be a close reflection of the truth. Obviously, as we heard, there's interest in capturing more cases. We'll do that over time. But I don't think that this is a circumstance where people should bet against the vaccine providing protection in 6-month to less than 2-year-olds that's higher than after 2 doses. I think that is, in fact, what we'll see.
Okay, thank you. So I'm just going to hit my 2 high points and then I'm going to turn it over to the others. But my two sort of high level comments are that I recognize that we can't actually compare neutralizing antibody titers across the different vaccine products. And that is my recollection from early in the pandemic. But it seems like it is challenging now as we're starting to leverage and use that as the key to get to authorization or approval, particularly for the younger age group. So comparability across trials, I feel like seems more important now than ever. And then this is just a generic comment. And then the second thing I just wanted to state is that, it's been really hard for us as parents and as pediatricians because recognizing that older adults were the group that was dying at the highest rate early on in the pandemic, it does feel like children have become the lowest priority in the pandemic. My request is just to continue to make them a priority. I think the durability of both effectiveness, immunogenicity, and efficacy are incredibly important. So just would really strongly ask that we continue to take a look at, longer intervals, how many doses are appropriate, et cetera, as we have this population in front of us that is still highly unvaccinated. So I still think rather than waiting for the post-market effectiveness studies to come through and for us to then retrospectively look at that data, I do feel like this is an opportunity for us to prioritize kids pregnant women, immunocompromised populations, and make sure we can do deeper dives into that prospectively, given that we continue to have a lot of uncertainty around the data. So thank you for indulging.
Dr. Lee, can I respond to both of those two things?
Oh, sure.
Okay. All right. So the last one, I couldn't agree more. After all, I'm trained as a pediatrician and infectious disease and vaccine specialist. So, my heart is in making sure that this happens. And I think, as you may have heard in the VRPAC presentation, we have plans to do just the things that you're talking about, not solely relying on the real world effectiveness, but also working to look at intervals, particularly as we get out of a pandemic period. I think as far as the former is concerned, you're absolutely right. It's dangerous, and I think a false way to go to compare efficacy against trials. And certainly in the circumstance where interval follow-up is particularly important, and we know that there are differences that occur over that period of time. Likewise, for immune response, it's dangerous and inappropriate to compare antibody responses, particularly given the differences in the assays. Where you can, though, make those comparisons, as I've tried to point out here, though, in a well-controlled circumstance where you're essentially running, in this case, the pediatric assays at the same time as you're taking sera from the adults. So these are not historical results. We're running these at the same time in the same assay to make these comparisons. And where you can show that, hey, we've got good antibody response after the third dose compared to what we see in adults for Omicron, I think you can take that to the bank with some confidence that, okay, that's likely to predict efficacy, as it did here, given the descriptive efficacy we provided.
Thank you. Dr. Daly.
Yeah, thanks so much. Some of the issues that I was going to raise were covered by Dr. Lee, but I do think there's still a couple points that I would like to discuss. I mean, I think I'm going to try to focus my comments on the entire age range of 6 months to less than 5 years. And what I come away with is that the FDA established immunobridging criteria for emergency use authorization, and those criteria were not met for a 2-dose series, and they were met for a 3-dose series. And so I think of this as a 3-dose primary series. And I think that's important because I don't want parents to get the impression that 2 doses is sort of good enough. And so, I think when we talk about whether there's some separation after 2 doses, I think we need to be cautious about that. I'm interested in seeing that data, but again, I think we all need to approach this as we have evidence that this met criteria established by the FDA for a 3-dose primary series. Then I think this is a good slide to stay on if we could, which is that I also feel like the message that I've heard from parents is they want to know the full story. And it's in the interest of transparency, and then they want to make the best decision that they can. So if parents are told we think a 3-dose series is 80% effective or has a vaccine efficacy of 80%, I'm concerned that parents are going to misunderstand our certainty in that estimate. So could you talk to the audience about what a confidence interval of 13.9 to 96.7 means when parents are trying to interpret a statement or a press release that we have vaccine efficacy of 80%? And then I have some additional questions.
Yeah, so let me address the second question, I guess, first. I mean, the first question, well, actually, let me speak to the first question. Obviously, we are getting approval as a 3-dose series, but I think it was important to share the post-dose 2 data because I think there have been some misconceptions that nothing was being seen in terms of the potential for at least some efficacy after the second dose. And it was really a conscious choice on our part to move forward with a 3rd dose because we thought, again, to your point, it's in the best interest of children. And I really think that there is no circumstance in which, frankly, 3 doses aren't going to be required to provide that level of protection. As far as the confidence interval is concerned, obviously over time, there's some expectation that we will get more precision. And as I mentioned, we have the potential to acquire additional cases since the cutoff of April the 29th, which of course still was during a period of time when Omicron was circulating, that we can further inform what this efficacy is. But we're at this point in time now, and this is the data we have, and I think the need is urgent to start immunizing children to get 3 doses in, because the future is uncertain, and we often find ourselves on our back foot, trying to catch up. I think in this context, it really means that 95% of the time, looking at the top number here of 80.3, that the efficacy is going to be somewhere between 13.9 and 96.7, but with the center of the curve around 80.3%. So most of the curve is in a circumstance where you're likely to have a high degree of efficacy given this case split, remembering that this is a 2-to-1 randomization. I don't think that this is much different than other sorts of efficacy that we've been hearing about today, whether we're talking about 2 doses or 3 doses. In some circumstances, I think the confidence intervals, depending on the definition, can be in this range. So my sense is that the totality of the data needs to be kept in mind here, that the nature of what we see in terms of antibody response, particularly to Omicron after a 3rd dose, provides some reassurance. The experience that we've seen in other populations after a 3rd dose where that level of antibody has been achieved provides us some confidence. And limited as these numbers may be, they're in the right direction. They're consistent with what we're seeing, and our anticipation is that real-world effectiveness data, as well as any further data that we can acquire from the controlled trial, should also be consistent.
Yeah, thanks for that, Dr. Gruber. I just think that if there's a press release about 80% vaccine efficacy, that there's some assumption that there's a fairly high degree of certainty around that. And this shows that the confidence intervals are wide. And again, I think, I have the same hope that you do, that the efficacy is high and matches the immunogenicity data. But I feel like in the interest of sort of full transparency to parents, it's to me appropriate to acknowledge the uncertainty around that as well. So if you could go to slide 20.
You are muted. You can mute or unmute yourself by pressing *6.
Series, and I'll wait for a sec till we get to slide 27. I'm still seeing slide 34.
There we go.
Yeah, so part of my confusion stems from the number of different comparisons were made and then who the comparison group was. So a 2-dose series in kids 6 months to less than 5 years of age did not meet the criteria for emergency use authorization, but a 2-dose series in adults did. And so when we're comparing, is this comparing a 3-dose series in kids to a 3-dose, yes, three vaccines received? But in those 18 to 50-year-olds, that's a different context, correct? Because that's 2 doses, which met criteria, and then a subsequent booster dose, which I think of as different than receipt of a 3-dose primary series in kids. And the reason I bring this up is also in the it's both, how do I interpret this? And then it's also
let me see if I can. So just to be clear, that the comparison here is different than what we were talking about in terms of the non-inferiority criteria, non-inferiority comparison to meet success criteria. In this case, we're specifically focused on, okay, what is the coin of the realm here in terms of something we could potentially hang our hat on that would allow us to predict efficacy? And I think the level of antibody response that we've seen to Omicron after a 3rd dose in older populations, it comes the closest to anything that we have to sort of saying, okay, when we got a higher antibody response, we had higher efficacy. And so making that assumption in this context where these individuals got 2 doses, but note the interval with a booster dose at basically 13 weeks, which is pretty close to the 10.6 weeks and the 12.9 weeks that you see in the 2 to less than 5-year-old and 6 months to less than 2-year-olds, respectively, after they got the 3rd dose. So in my mind, whether we call it a primary series or we call it 2 plus a boost, in this circumstance, we're comparing the same type of series. And I think you've heard argued, and I would subscribe to this, that in a world of Omicron, we're frankly talking about a 3-dose series for everybody. 3 doses are required to protect against Omicron. And so we've done the best job that we could to compare like to like, 3 doses with the 3rd dose, with the difference between the 2nd dose and the 3rd dose essentially standardized here, so we could be comparing like to like, and we're getting a similar GMT, which should provide a similar level of efficacy. And again, despite the limited numbers, the efficacy that we're seeing matches the sort of efficacy that we're seeing in this circumstance in adults, which in my mind, and we have others that can speak to this, is in the 70 to 80+% range.
Well, I would disagree with so I appreciate that, and thank you for running through that with me. I would disagree in some ways with the assumption that this is like to like in all contexts, because obviously it's an older age range, but it's also at a 30 microgram dose, which is 10 times the dose that we're studying in children. And so, I want to make sure not to make too many assumptions about the protection that a 3-dose primary series in kids 6 months to 5 years conveys. And again, whether a booster dose will be needed in this age range. Again, I feel comfortable with the fact that a 3-dose primary series has met the criteria for emergency use authorization, and I'm also anxious to get kids immunized and protected. But again, I feel like there are similarities in the 3 figures being shown here as you highlight, but there are differences. And I also want to acknowledge the differences, because I don't want to make too many assumptions about whether a booster dose will or will not be needed in kids 6 months through less than 5 years of age on that basis.
Yeah, maybe can I respond to that?
Please.
Oh, yeah. So let's face it. In the older adults, we're already talking about 4th doses that are being administered to high-risk populations. We're obviously contemplating what our future will be, informed by the VRPAC meeting that's going to happen at the end of this month about what we do in the fall. So I think sort of discriminating, well, are the kids going to require a booster dose as opposed to the adults? I think everybody's going to require a booster dose, and it's just a matter of discerning with real-world effectiveness data and perhaps some of the additional control data when that booster dose is likely to occur. So I think for the purposes of this comparison, I just want to emphasize that this is after 3 doses in both groups at comparable sort of intervals of administration. We're getting the type of antibody that is likely to be associated with protection in the 70, 80+% range that we're seeing in adults, and the descriptive efficacy is matching that. So for this type of regimen, as a primary series in young kids, we're likely to see effectiveness that matches what we've seen in the clinical trial. I think, again, I would not bet against the vaccine here in this context.
Well, and just to be clear, I'm not betting against the vaccine. I'm just arguing for as much transparency about what we know and don't know with parents. And that includes sort of what to expect after a 2nd dose and what to expect about whether additional doses will be needed. In that context, can you let us know about when you may have studies of safety and immunogenicity of a 4th dose in kids 6 months through 5 years of age? Thank you.
Yeah, so I think obviously that's under discussion, as well as what we decide to do, informed by the VRPAC meeting at the end of this month. We already have plans afoot and are putting protocols together basically to look at moving forward with an Omicron vaccine or an Omicron plus a reference strain vaccine, or potentially other options that may be put forward in the setting of BA4 and 5. So we're going to tailor this to what seems to be best suited for what the future is most likely to bring in the fall. And so that work is already underway, and we're are in and will be in further discussions with the FDA about that. But I think it does need to be informed by the decisions that are made at this month, so we don't go off on a tangent for something that, frankly, doesn't become the vaccine in the future.
Okay, thanks so much.
Thank you, Dr. Daly. I'm going to hand it over to Dr. Fink to respond, and then we're going to go with short questions for the last 3, and we have to move on to Dr. Oliver's presentation after that.
Thanks, Dr. Lee. While this slide is up, I just wanted to say a few things in the interest of full transparency. So first of all, this slide represents late-breaking data that Pfizer provided to us just shortly ahead of the VRBPAC, and we haven't had a chance to verify these immunogenicity analyses. Secondly, in the interest of comparing like to like, I just want to point out that a median 13-week interval between dose 2 and dose 3 is not an interval that has been evaluated, as far as I know, for efficacy in adults. And so I would stress that we should be careful in trying to compare expected efficacy with this sort of dose 2 to dose 3 interval based on immunogenicity, looking at these pediatric age groups versus adults. Now, that being said, what we have seen time and time again with the data for these vaccines is that there is some level of efficacy after the first dose, and it increases after the second dose and increases again after the third dose. So it would not be unexpected that for this 3-dose primary series, the protection afforded by the third dose would be higher than the protection afforded after the second dose. We just don't have the confidence at this time, based on the small number of cases that are available to us, to cite a specific efficacy estimate. Thank you.
Thank you. Really quick questions, Dr. Paling.
Dr. Gruber, I wanted to ask you about febrile seizures. Did you have any febrile seizures, and what can you tell us about that in your study? Thank you.
And I'm happy to do that. Maybe, Charlie, if you can identify again the slide to bring up.
Sure. Yeah, slide 43, 44, and 45. We can start with 43. Thank you.
Yeah, so let me talk first of all about febrile convulsions, because obviously in the setting of fever, and part of the reason we want to minimize fever with this vaccine series is to minimize this as a potential complication in those children that are predisposed. So we had 5 participants that had febrile convulsions. All were assessed as non-related to vaccine, and you can get some sense of why, because look at when they occurred with respect to vaccination. They were well distant from vaccination, whether we're talking about 6 months to less than 2-year-olds, or the 2 years to less than 5-year-olds, in association with other potential causes, except I guess for the last one that was down at the bottom, that was 21 days post-dose 1 in the vaccine group. And then if we go maybe to, would it be the next slide, Char, that talks about the
correct. If we go to the next slide, 9.
Yeah, so if we go to the next slide, please. I'm not seeing it up yet on my screen. There we go. So for non-febrile convulsions, we had 6 participants had non-febrile convulsions. All were assessed as not related. One was a seizure, or what was believed to be a seizure, with eyes rolling back 2 days post-dose 2 in the 6-month to less than 2-year-olds in the vaccine group. Another seizure, 164 days post-dose 2, down at the 2 to less than 5, 147 days post-dose 2. In a case of status epilepticus, 18 days post-dose 1, and someone known with a medical history of seizure disorder. So on balance, we think that, again, we're gratified that we've not seen, febrile convulsions that seem to be related to this vaccine, and nor do there seem to be related non-febrile convulsions. And I think, convinces us of, again, a satisfactory safety profile that I think is, again, enlarged by the fact that the level of fevers that we've seen has really been gratifyingly low.
Thank you. Dr. Sanchez, quick question.
Yes, I just wanted to know, were any of these mothers of these, especially of the younger children, vaccinated with, with COVID vaccine, or specifically with Pfizer, or was that an exclusion? And if they were vaccinated, how did you interpret antibodies baseline?
Yeah, so again, Char, you can remind us about the nature of the history that we obtained on these folks. I think one of the things to keep in mind, of course, is these children are starting to get vaccinated at 6 months of age. So the presumption is that any sort of passive antibody that they would have would likely have declined by the time that those children receive vaccine. I think, Dr. Sanchez, your question obviously becomes that much more important when we talk about children less than 6 months of age, and that'll clearly be an important part of the history. But Char, you want to just speak to the, what was discerned, if anything, about individuals that were vaccinated prior, and then I can make one other comment.
Sure, no, appreciate that. So we are collecting that data in terms of a maternal vaccination that's currently ongoing. We have not conducted a separate analysis, but as Dr. Gruber mentioned, it'll be part of what we look at. We don't have any other, we do have their baseline antibody testing for all children. They did have N binding at the time of entry into the study.
I will say something that will potentially be of interest, as I think maybe you know, we have a study 1015 in pregnant women who are vaccinated actually at the time of pregnancy, and we will be evaluating antibody in those children over time that are born. I think there, as you're aware, there is some information in the literature about protection afforded to those children by maternal immunization that looks promising, and that also actually impacts our thinking about, okay, well, what is the best course for protection of children less than 6 months of age that figures into our discussions with regulatory authorities.
Thank you. I mean, it could go both ways also, as to whether there could be some interference if there is persistent maternal antibody. But thank you.
Thank you. And very last quick question from Dr. Long, and we do have to move on to Dr. Oliver's presentation and public comment, and we are running behind. So Dr. Long.
Yes, since the majority of children for whom we would potentially give this vaccine are already seropositive, I'm interested in the cadence of the response and the final antibody level in the 5-6%, I think, who were seropositive prior to immunization.
I don't know that I can, Dr. Long, I don't know that I can address the cadence because we didn't get serial sampling on these children. We actually have slides that show the antibody responses increased in those individuals that were seropositive, not surprising based on other experiences we've had in other populations. But in the interest of time, maybe there's not a need to show that.
I'm okay with that answer. I just, when the primary infection for viruses sometimes is early in life, and these would have been in the first 6 months of life that they had their primary infection, or they still had antibody from maternal immunization now. Funny things can happen with immunization that they don't respond. So I'm happy enough to hear that they were at least as good as those that were seronegative.
Yeah. This was true for both the 6 month to 2 year olds as well as the 2 to 5. So it looks like even though those, as you said, some of those individuals by definition will have had to have been infected before 6 months of age to register, or they were PCR positive at the time that they actually were enrolled but asymptomatic. I think that's encouraging that in fact we still saw a good response above that actually seen in those that were naive.
Thank you.
Thank you. And thank you, Dr. Gruber, for patiently answering our questions today. Then we will move on to Dr. Sarah Oliver, who will be reviewing this information on mRNA COVID-19 vaccines in young children, providing a summary and workgroup interpretation.
Thanks so much, and good afternoon. Next slide. So I'll just briefly summarize the data we've seen so far today, a workgroup interpretation, and next steps. So first we'll talk about Moderna. Next slide. As a reminder, the trial was conducted from December of 2021 through, of 2021 through February of 2022, with case accrual after a second dose at the height of the Omicron surge. Children were ages 6 months through 5 years of age in the US and were randomized 3-to-1 vaccine to saline placebo. The analyses were performed separately for 6 to 23 months and 2 to 5 years, and we have results pooled for a combined estimate for 6 months through 5 years. The Moderna schedule is 2 doses of 25 micrograms separated by 28 days, and the median follow-up time post-dose 2 is 2.5 months. Next slide. For the overall population, there were over 6,000 children included in the efficacy and safety analyses, again randomized 3-to-1. Then there was a subset of nearly 500 children included in the immunogenicity analysis. Next slide. For the efficacy endpoints among subjects with or without evidence of prior infection, for those 6 to 23 months, the VE was 50.9%, and for 2 to 5 years, the VE was 37%, for an overall VE of 41.5%. We have higher confidence in this estimate based on 181 COVID cases in the vaccine group and 97 cases in the placebo group. In addition, the efficacy in this trial is consistent with the post-authorization vaccine effectiveness for the Moderna vaccine in adults 18 through 64 years during Omicron, where the VE against infection 2 months after dose 2 was 35%. Next slide. Then regarding immunogenicity data, the antibody levels were measured 28 days after the second dose for participants without prior infection. The antibody responses after 2 25 microgram doses in children ages 6 months through 5 years, compared to 2 100 microgram doses in individuals aged 18 to 25 years, met the non-inferiority criteria with the ratios shown here. Next slide. Then regarding safety data, no deaths were reported in any trial participants. Serious adverse events were rare overall, occurring in 0.5% of vaccine recipients and 0.2% of placebo recipients. One vaccine recipient had 2 SAEs, a fever and febrile seizure, that was deemed possibly related to the vaccine by FDA. No cases of myocarditis or anaphylaxis were noted in any trial participants. Next slide. Local reactions, such as pain at the injection site, were common, and systemic reactions also occurred. In the children ages 2 through 5 years, fatigue and headache were the most common, and in the younger children 6 through 23 months, irritability and sleepiness were most common. Symptoms typically started 1 to 2 days post-vaccine and resolved after 2 to 3 days. Next slide. Fevers were more common after vaccine than placebo, and more common after dose 2 than dose 1. Most fevers were reported in the first few days after vaccine and lasted for around a day. The table at the bottom shows fevers after the second dose at 16%. However, fevers for other routine vaccines given at this age, such as the pneumococcal vaccine, can be around 30%. Then, as we heard from Moderna, there was 1 febrile seizure that was possibly related to the vaccine. Next slide. The work group also noted imbalances with some respiratory infections, such as RSV. However, when taken for all respiratory infections, including COVID, no imbalances were noted. The events were rare in less than 1% of trial participants. In addition, there was no patterning or clustering of the cases, and the clinical consistence were typical and consistent with the seasonal respiratory infections. In addition, testing was not performed systematically for all patients and was at the discretion of the clinician evaluating the patient. Because of this, testing for additional respiratory pathogens varied and may have varied by the results of COVID-19 testing. Then for the Moderna trial, lymphadenopathy was a solicited adverse event. So lymphadenopathy, either in the axillary region or the groin, was noted in 9% of vaccine recipients compared to 2% of placebo recipients. Next slide. So in conclusion, the efficacy seen after 2 doses of the Moderna COVID-19 vaccine in children ages 6 months through 5 years of age is consistent with real-world vaccine effectiveness in other ages during Omicron predominance. The antibody levels after 2 doses in children ages 6 months through 5 years produces similar antibody levels seen after 2 doses in individuals aged 18 through 24 years. And the reactogenicity post-vaccine is consistent with other recommended vaccines in this age group. Next slide. Moving to Pfizer. Next slide. So to describe the clinical trial, the trial was conducted from June of 2021 through April of 2022. Children ages 6 months through 4 years in the US were randomized 2-to-1 vaccine to a saline placebo. As always, as we heard before, the analyses were performed separately for the two ages and then pooled for a combined analysis. This series is 3 doses of 3 micrograms each. Dose 1 and dose 2 were separated by 21 days. Then dose 2 and dose 3 are separated by at least 8 weeks. However, note the interval between dose 2 and dose 3 in the trial is longer than the authorized interval. Among children 6 to 23 months, the interval was 16 weeks with a range of 8 to 32 weeks. And for children ages 2 to 4 years, the interval was 11 weeks with a range of 8 to 34 weeks. In addition, the median follow-up time post-dose 3 was 1.3 months. Next slide. Then I just want to walk through some of the timing with the Pfizer trial. For children 2 to 4 years, they began giving the first doses in June and second doses starting in July. However, per protocol, they began unblinding participants 6 months after the second dose, which was around December of 2021 and into January and February. Then, as we're aware, based on analyses after the second dose, the protocol was amended in February and third doses were given. However, by then, many of the initial cohort from the trial were unblinded and placebo crossover had already occurred. After FDA's request to expand the size of the trial, they began an expanded enrollment, initially extending for an expanded safety enrollment. This cohort began receiving doses in October and November, with, again, third doses starting in February and March. But if we look at the bottom, you can see we have blinded person time contributing to the dose 3 efficacy and safety evaluation from February through April, which was when the cases began declining after the Omicron surge. Next slide. This slide walks through everything again with the 6 through 23 month population. The same phenomenon occurred where participants were unblinded 6 months after the second dose. Next slide. So if we walk through the impact that had on the total number of participants who contributed blinded person time to the efficacy and safety evaluations, on the left in the 2 to 4 years, you can see they started with 2,700 children in the 2 to 4 year group, and then on the right, in the 6 to 23 month group, started with around 1,700 children. By dose 3, much of that population had been unblinded, and overall 32% of the overall eligible population contributed blinded person time to the efficacy and safety evaluations. Next slide. So then this slide shows the efficacy estimates after the third dose. For those 6 to 23 months, 75.5%, and for 2 to 4 years, 82.3%. Overall, in the 6 months through 4 years, 80.3%, but note wide confidence intervals for all. We have lower confidence in this estimate as these were based on 3 cases in the vaccine group and 7 cases in the placebo group. For comparison and context, the post-authorization vaccine effectiveness for the Pfizer COVID-19 vaccine in adolescents aged 12 to 15 years during Omicron, the VE against infection 2 months after dose 2 was 29%, and 2 months after dose 3 was 43%. Next slide. Overall, the work group felt that the post-dose 3 efficacy data are difficult to interpret. There is a limited number of cases during the blinded follow-up. In addition, the protocol specified a need for 21 cases prior to the formal efficacy analysis, and only 10 were included in the interim descriptive analysis. Importantly, the dosing interval between dose 2 and dose 3 varied and are longer than the authorized interval. And the median blinded follow-up time is limited, with a median time of 35 to 40 days for the age groups here. Next slide. Again, the antibody levels were measured 1 month post-dose 3 for participants without prior infection. Antibody responses after 3 microgram doses in children 6 months through 4 years were compared to 2 30 microgram doses in individuals aged 16 to 25 years. Both age groups met the non-inferiority criteria with the ratios shown here. And the numbers included in the population here were 225 children total. Next slide. Then for comparison and context, the work group again reviewed the results that were seen after dose 2. For 6 months to 23 months, minimal VE was seen, but the non-inferiority criteria were met. For 2 to 4 years, some protection was noted with a VE of 33%, but the non-inferiority immunobridging criteria were not met. Next slide. From a safety standpoint, no deaths were reported in any trial participants. Again, serious adverse events, or SAEs, were rare overall and occurred in 1% of vaccine recipients and 1.5% of placebo recipients. One vaccine recipient had 2 SAEs, fever and pain in an extremity requiring hospitalization, possibly related to the vaccine, but the FDA felt symptoms were potentially consistent with a viral myositis. And again, no cases of myocarditis or anaphylaxis were noted in trial participants. Next slide. Local reactions such as pain or tenderness at the injection site occurred within 7 days and were common. Fatigue was the most common systemic symptom in children 2 to 4 years. Irritability and drowsiness were more common in children ages 6 through 23 months. Overall, the reactions were comparable after dose 1, 2, and 3. Most symptoms were mild and resolved after 1 to 2 days. Next slide. Then specifically for fevers, fevers were reported with similar frequency after both vaccine and placebo, and similar frequencies after doses 1, 2, and 3. Frequency after the second and third doses are shown here. Then most fevers were reported on days 1 and 2 after any dose and lasted for a median of 1 day. Next slide. So in conclusion, antibody levels after the 3 doses in children ages 6 months through 4 years produced similar antibody levels after 2 doses in individuals aged 16 to 24 years. Reactogenicity post-vaccine was similar after each of the 3 vaccine doses and similar to reactions seen in placebo recipients. However, the efficacy estimates after 3 doses are difficult to interpret given the small numbers and limited follow-up time. And the work group noted that the impact of the longer interval in the trial between dose 2 and dose 3 on efficacy, reactogenicity, and safety are unknown. Next slide. So the work group interpretation in total. Next slide. The mRNA COVID-19 vaccine clinical trials in young children were both conducted during Omicron predominance, but at different months and incidence levels. So in addition to differences in the number of participants in the efficacy analyses and differences in follow-up time, these incidence levels impacted COVID-19 case accrual and certainty in the efficacy estimates. Because of this, the efficacy estimates for these 2 mRNA vaccines cannot be directly compared. However, both vaccines met the non-inferiority criteria for neutralizing antibody levels. Next slide. Note that the current data are for either a 2-dose or a 3-dose primary series. To achieve the criteria set by FDA for authorization, 2 doses for Moderna or 3 doses of the Pfizer vaccine were required. For ages 5 and over, 2 doses achieved the preset efficacy requirements or the required antibody levels for immunobridging. A booster was then provided to optimize the immune response and address waning of antibody titers detected after completion of the primary series. Post-authorization effectiveness studies can help determine the subsequent timing and need for boosters after a 2-dose with Moderna or 3-dose with Pfizer primary series. That booster would then be a 3rd dose for the Moderna vaccine and a 4th dose for Pfizer in this age group. Next slide. However, we do know that in other age groups during Omicron, the mRNA COVID-19 vaccine post-authorization vaccine effectiveness was lower against infection, but higher protection was noted against severe disease, as we heard from Dr. Link-Ellis earlier today. The clinical trials were not powered to detect efficacy against severe disease in this young population, but similar patterns in this age group are expected to what we see in everyone ages 5 and over. Next slide. Then for next steps, The evidence to recommendation framework, including the grade summary of the data, will be presented tomorrow. For ETR tomorrow, we will be discussing 2 separate policy questions. So should vaccination with the Moderna vaccine be recommended for children 6 months through 5 years of age under an EUA? And should vaccination with a Pfizer vaccine be recommended for children 6 months through 4 years of age under an EUA? We will not be comparing the 2 vaccines. We'll be comparing each vaccine to no vaccine. Next slide. Just want to acknowledge our team that helped pull all of these slides and a careful review of the data. Next slide. That's it. I'll turn it back over to you, Dr. Lee. Thanks.
Thank you, Dr. Oliver. This presentation is now open for questions. Dr. Lair.
Thank you, Dr. Oliver, again for a lovely presentation, very informative. I want to see if you can convey the nuances the work group felt about the Pfizer vaccine and the difficulty in evaluating the efficacy compared to it meeting the FDA criteria, and if that was enough to give the work group pause about approval for the Pfizer vaccine.
Thanks. I'm happy to maybe kind of start that discussion and then we can finish it tomorrow, because I do think some of this may come out in some of the ETR determinations as we walk through everything. I will note, the work group again discussed that with the 2 doses of Moderna or with 3 doses of Pfizer, it met the criteria set out by FDA to grant the EUA. So I think the work group was reassured in that, but there was considerable discussion about the differences both in the follow-up time and the fact that there was limited kind of person time, both by number of participants and by time after that 3rd dose with Pfizer, and considerable discussion that we'll need to monitor post authorization, safety and effectiveness very closely with both vaccines, as we always do, but that it'll be especially important with Pfizer as we're watching what the efficacy ends up being, especially given the fact that it is likely that many children or most children will receive the vaccine at that 2nd to 3rd dose at an 8-week interval, and that the data to inform what that effectiveness looks like is actually pretty limited based on the trial. And I don't know if Dr. Daly wants to comment anything else or if he thought that was.
Actually, I think we're limited on time, so why don't we wait until tomorrow to address some of these other issues.
Thank you. Dr. Long?
I don't know if you want to wait till tomorrow to discuss this, but I think we should discuss what you've just been talking about. And I decided when I first saw these data, especially about Pfizer's efficacy data, that I think we should just assume we don't have efficacy data. And I think that I would be comfortable enough with the immunobridging. And that I think should be something that we should discuss, but we certainly have done other vaccines where we have not had enough time or the capability of efficacy that we've used immunobridging. So although we don't have that magic number, we do have the data that if you think that the antibody tests as they're performed by different pharmaceutical groups are measuring the same antibody and are comparable with the ones that they have done in other age groups, I'm not uncomfortable with considering that we don't have efficacy data.
Dr. Fink, did you want to respond?
I just wanted to echo what Dr. Long said, that from FDA's perspective, we would have been confident in the clinical benefit of this 3-dose primary series based on the immunobridging data alone, even if there were no efficacy data available. And where we're less confident is quoting a specific efficacy estimate. Thank you.
Thank you. Dr. Daly, did you want to add anything?
Oh, just that from the COVID vaccines work group point of view, our discussion was very much along the lines of what Dr. Long said, and our interpretation was along the lines of what Dr. Long and Dr. Fink said. Thank you.
Are there any additional questions or comments for Dr. Oliver? And I don't want to stifle discussion, but I do want to make sure that I want to make sure we have enough time for that discussion, because I think it's incredibly important for our consideration of the votes. But we do have an additional day tomorrow for this discussion with additional context from presentations. Any other questions from our ACIP members or our liaisons? Okay, I don't see any additional hands raised at the moment. What I'd like to do is ask if our colleagues in the room at CDC can prepare us for a public comment session. I think what I'll do is just take a 2-minute break as we ask our public comment speakers to get online, and then we will begin with the public comment session in 2 minutes. Thank you. Terrific. Actually, we're back a little bit sooner because all our public comment speakers are on. So we'll reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and apologies for starting us late. And in order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a reminder, ACIP is very interested in hearing public comments about the agenda topics being discussed today. Our committee appreciates diverse viewpoints that are respectful in nature and issue focused. We do ask speakers to share their views about the issues being discussed, rather than comments about individuals. And I want to thank our speakers again, and we look forward to your comments. So the first public comment speaker I have is Daniel Rocker.
Good afternoon. My name is Daniel Rocker, and I'm speaking today on behalf of Retire Safe, a grassroots nonprofit organization formed in 1991. Retire Safe's mission is to educate and advocate on behalf of mature Americans on issues including Social Security, Medicare, health, safe retirement, and financial well-being. We're grateful to have the opportunity to present our comments today. As we've said many times before in both oral and written comments of this committee, the importance of vaccines cannot be overstated. All of us, from the youngest to the oldest, are at risk from COVID-19. We know the devastation it has caused on older Americans, as over 75% of deaths have been among adults 65 and over.
Apologies. I hate to interrupt. I'm so sorry, but the timer is not working on the screen. So I just want to ask my CDC colleagues if they could start that.
Do I restart or continue?
No, please go ahead and continue. Thank you.
Okay, thank you. Nonetheless, seniors were among the first group to become eligible for vaccination and took full advantage of it. 95% of those over the age of 65 have received at least one shot, and over 91% are fully vaccinated. But for many seniors, concern, even fear, was not so much about themselves, but for their families, especially their grandchildren and their great-grandchildren, who who have had no access to protection. Yesterday, that long wait ended with the FDA's authorization. Now we look to you to give recommendations that will enable providers to begin to protect our smallest loved ones with these life-saving vaccines. We thank you for the swiftness in which you have met today only one day after FDA. Retire Safe would like to ask one more thing. The threat of COVID has been and remains unprecedented, especially to older adults. But it's not the only danger to older Americans' respiratory health. Last year, the FDA approved 2 pneumonia vaccines, which are of enormous value to seniors, millions of whom are still waiting for this committee to issue recommendations for their situation. We're so thankful for ACIP's immediate turnaround time for COVID for young children. We ask you to please act swiftly now on behalf regarding pneumonia disease. Thank you.
Thank you very much for your comment. We will move to the next public comment speaker, Mrs. Kate Schenk.
Good afternoon. Thank you for allowing me the opportunity to speak today. My name is Kate Schenk. I'm the mother of 3 children under the age of 5. The last 2.5 years have been long and challenging for families like mine who have young children. My husband and I have done everything we can to protect our children from COVID-19. Our children haven't been inside grocery stores or department stores, let alone typical childhood staples, such as indoor amusement parks, museums, malls, and restaurants. A safe and effective vaccine for children under 5 will allow our children to experience the joys of playdates, vacations, family gatherings, and so much more. My oldest child is incredibly excited to be starting kindergarten this September, but she doesn't turn 5 until mid-August. Moderna's under 5 vaccine will allow her to start the school year fully vaccinated. Both Moderna and Pfizer are safe and effective vaccines. They have met immunobridging with similar efficacy to adult vaccines during the Omicron surge. Their safety profiles are excellent, both in the pediatric trials as well as in the millions of doses that have been given to older cohorts. These vaccines can protect against the most severe of outcomes, the things that have worried parents since the beginning of the pandemic, death and hospitalization, and can potentially decrease the risk of other complications, including long COVID, MIS-C, neurological effects, diabetes, and hepatitis. At this point in the pandemic, many people have seemingly moved on and are completely forgoing COVID mitigation efforts, such as masking and social distancing, and our youngest children have been left behind, unprotected. Those without children do not even recognize the toll this has taken on young families, since we have become invisible while they are living life as normal. Vaccination can change this. Please recommend COVID-19 vaccination for all children under the age of 5. We know that COVID-19 affects children. In April, it was estimated that 3 out of 4 children have had COVID. Millions of children have been infected. 4 times more children have been hospitalized this year with the Omicron variant than with Delta last year, and the largest increase was in children too young to be vaccinated. 482 children under age 5 have died. In addition to recommending vaccination for all children under age 5, please ensure that all children have easy access to the vaccine. Low-income families, families who rely on public transportation, and families without an established pediatrician need to be given the opportunity to vaccinate their children promptly. Anything that can be done to provide easy and equal access to vaccination should be prioritized. After all, we've been waiting so long for this. Finally, the delays we have seen in the under 5 vaccine have been frustrating and have undoubtedly led to illness, hospitalization, and death during the wait. In the future, for pediatric boosters and other vaccines, please ensure greater prioritization and expeditious review is given so our children are not left behind yet again. I urge you to please approve these vaccines today so parents will have the ability to protect their children from COVID-19. Thank you for your time.
Thank you for your comment. Next, we have Mrs. Caitlin Calm.
Good afternoon. My name is Caitlin Calm. Thank you so much for the opportunity to speak today. I am a 2nd grade special education teacher and the mother of a pandemic baby, a determined, joyful, spunky 2.5-year-old. I have no conflicts. I am here today to advocate for vaccine access for children under 5. I know that you are well versed in the data of this pandemic, so I would like to take a moment to speak to the personal side. My daughter has lived all but the first 3 months of her life in a pandemic. We have followed all of the CDC guidelines throughout, which for her means that she did not get to have a first birthday party. We have missed out on celebrating several holidays with family. She has never been to indoor spaces like museums, and she has missed out on countless other activities that are normally considered typical for a child her age. She lives vicariously through books, and it is heartbreaking to hear her say, "Mama, someday I will go to an aquarium like Curious George." Or, Mama, sometime we will go to a grocery store like Pete the cat. These are things that should be taken for granted, not things that have a mythical connotation. It is also heartbreaking to watch her give her stuffed animals a COVID test during her pretend play, and then turn to me to say, "Don't worry, Mama, the COVID test is negative." Each day, I have to weigh the risk of every activity, as all mitigation measures have been dropped and there are no protections for my daughter, other than the ones I can cobble into place. Each day, I put a very small mask onto her little tiny face and hope that it will be enough to keep her safe while she is at daycare, while knowing that she must spend several hours unmasked while she eats 2 snacks and a lunch and while she naps. Each day, I check the wastewater levels in my section of the state to see what direction they are trending in. I try to complete some complicated mental calculus to figure out how much risk I'm exposing her to on a daily basis, between her time in daycare, my exposure as an elementary special education teacher, etc., and I'm exhausted. So far, we have been lucky and are part of the very small percentage of people left in this country who have not been infected by COVID. I am concerned about the unknown long-term ramifications of COVID infection, especially for someone who is unvaccinated like my child. A vaccine, while not a magic bullet, would certainly change all of this for us. Moderna and Pfizer have both demonstrated that their vaccines are safe and effective. Both met the immunobridging standards and both protect against severe illness, hospitalization, and death. Both vaccines demonstrated similar efficacy to the adult dose during the Omicron surge. Children under 5 deserve to receive the protection that these vaccines provide, just like everyone else in the country, and their parents deserve to be able to make a choice between the 2 vaccines. These delays that have persisted throughout this process for children under 5 cannot be allowed to happen again. Many children have become sick, have been hospitalized, and have even died while waiting for approval of these vaccines. I cannot urge you strongly enough to approve these vaccines today for children under 5 to provide parents with the ability to protect their children. Thank you again so much for giving me the time to speak today. I appreciate it.
Thank you for your comment. Next, we have Dr. Andrea Klein-Tilford.
Greetings. I am Andrea Klein-Tilford, and I do not have any conflicts to report. I'm a pediatric nurse practitioner and the president of the National Association of Pediatric Nurse Practitioners, a professional organization representing more than 8,000 pediatric-focused nurse practitioners. We support the timely and complete immunization of all eligible infants, children, and adults to maximize the health and well-being of all people. In the United States, children have accounted for roughly 19% of all reported COVID-19 cases. While some children experience few or no symptoms, some children with COVID-19 develop long-term complications, severe illness such as multisystem inflammatory syndrome, require hospitalization, or worse, die from COVID-19. According to the CDC, hospitalization rates of children under 5 during the Omicron surge were 5 times the rate during the previous Delta variant. It's critical that children of all ages have access to safe vaccines as soon as possible to prevent disease and hospitalization as COVID continues to spread and mutate and before we enter the traditional flu and RSV season. Experts agree that the first 5 years of a child's life are especially crucial regarding physical, intellectual, and social emotional development. During these early years, the brain grows faster than at any other stage in life, with many in this age group being too young to adhere to the mitigation strategies such as consistent physical distancing and mask wearing. Your approval of COVID-19 vaccines for children under 5 would significantly help protect this age group and allow many families to return to a sense of normalcy. COVID vaccines have the potential to help young children enjoy typical age-appropriate socialization and achieve developmental milestones that are critical for their long-term physical and mental health. For months, parents and caregivers of young children have been desperate for a safe, effective vaccine. Based on the available safety and efficacy data, NAPNAP urges ACIP to approve administration of the Pfizer-BioNTech 3-dose vaccine for children 6 months through 4 years and the Moderna 2-dose vaccine for children 6 months to 5 years, based on the FDA's emergency use authorization recommendation. We also call on the FDA and CDC to work with manufacturers and state and local agencies to provide comprehensive, equitable vaccine delivery to every eligible child in the United States as quickly as possible. Being able to vaccinate all people 6 months and older means we'll finally have the necessary tools to fight this ongoing pandemic and improve our nation's public health. Thank you for this time to share the views of the National Association of Pediatric Nurse Practitioners and my own views as a mother of 2 children under 12 years of age.
Thank you for your comment. Next, we have Mr. Christopher Royster. Mr. Royster, I believe you are still muted.
Yes, can you hear me?
We can, thank you.
Thank you. I was having problems with my audio. Good afternoon. My name is Christopher Royster. Thank you for allowing me to present a public comment today. As I am a representative for Retire Safe, as mentioned by my colleague, Mr. Daniel Rocker. I believe that these meetings are very important and paramount for all age groups. Many have perished during this COVID-19 pandemic. However, the current state of our society is filled with adults, including the elderly.
Mr. Royster, could you pause the timer, please? Thank you. I think we've lost you, and we had a little bit of an echo too. Are you able to speak?
Hello?
There you are. Please go ahead. We'll add 20 seconds to your clock. Please go ahead.
Thank you. However, the current state of our society is filled with adults who are currently vaccinated, the same as the elderly. Thus, to protect the lives of our senior citizens, it's very important that you all pass these vaccination laws and make it a requirement for all of our youth. From listening to the presentations today, I believe that a 3-dose Moderna vaccination criteria is necessary for all age groups. After listening to the results and details of each presentation, I believe that Moderna has been proven to be an efficient vaccine thus far. With the limited time period for which the development of these vaccines have been subject to, and the 70% to 80% efficacy results for a 3-dose, which has been presented today, I believe that that is enough for me to believe that these vaccinations should be used and should be implemented for all children. Our youth are the future. Therefore, we must protect our children as they are the catalysts which will move our society forward. We must protect them at all costs. Thank you.
Thank you very much for your comment. Next, we have Amy Baker. Amy Baker, are you able to unmute your line?
She was on, Dr. Lee, but maybe she lost her connection.
Okay, thank you. Why don't we move to Evelyn Pinheiro?
Good afternoon. Can I start? I'm a parent to a 4.5-year-old and a 1-year-old, and I want to thank you for meeting so quickly, even on Father's Day weekend. Like you, I know that every day counts if we want our children to be vaccinated before infected. Every day more people take off their masks at my son's school. Every day I'm notified of new COVID cases there. And every day my unvaccinated children grow older without being able to travel to see grandparents and cousins. Previous speakers have already talked about hospitalization and death among children under 5 with COVID. One of the other risks that keeps parents up at night is the potential for chronic problems. Today is my 1-year-old's first birthday, and he has his entire life ahead of him. We don't know the long-term effects that this novel disease might have on the newly developing brain or lungs or heart. And we do not want to take the risk for our children of long COVID, which we know vaccines can decrease. So like thousands of parents, we continue to live like it's March 2020. While it takes a village to raise children, we are doing it alone and we're so tired. We miss getting to share the arrival of our babies with family and friends. We miss library story hours and indoor play dates. My older son, an avid dinosaur lover, is dying to get his COVID shot so he can go to the Natural History Museum. I want to be able to more safely visit with elderly loved ones. June 15th was like Christmas morning to the many 6,500 parents and doctors who belong to a group called Protect Their Future, formed to advocate for vaccines for under 5s. I implore you today to approve both vaccines as they were both safe and met the primary endpoints of immunobridging. But once these vaccines are approved, we also need help accessing them. My peers in Florida are frantic as they live in the only state that didn't order vaccines. Here in New York, where I live, state sites are closing and my county isn't offering the shot to under 5s. Pharmacies cannot vaccinate children under 18 months. Some pediatricians aren't offering the shot. For most of us, Moderna will be the only option to fully vaccinate our children before the beginning of the school year. Even though I live in a New York City suburb, the closest place I can find that will be giving Moderna to children under 18 months is 3 hours away. In addition to approving both vaccines for children under 5, please help give parents a choice of vaccines and more options for vaccinating our babies.
Thank you for your comments. Next, I'll ask if Amy Baker is on.
Yes, I was on. Sorry, I was trying to unmute with my phone and not *6.
That's okay. Please go ahead.
Thank you for giving me the chance to speak today. I can go through the facts, such as it's been 875 days since the first COVID case was reported in my state, and 481 children under 5 in the U.S. have died from COVID. But I'll stop there because I hope you know these facts given your position. Instead, I'll explain what our lives have looked like the past 27 months trying to keep our 1- and 3-year-olds safe from COVID. No daycare, quitting my job because no safe daycare, and it becomes impossible to balance the job and caring for my children once my spouse returns to the office. No first, second, or third birthday parties, missing weddings, missing funerals, no play dates or library story times, no peer social interaction for our children, no reprieve for us parents, day in, day out for 826 days. 231 days since children 5 and up could get vaccinated, and we thought it'd be a matter of weeks until it was our turn. 129 days since it was announced that Pfizer would be submitting for under 5s on a rolling basis at the FDA's request, and we thought it'd be any day. At a minimum, that's 129 days that pediatricians, county health departments, and medical offices have had to prepare and plan for the hopefully eventual administering of the COVID vaccine to children under 5. 129 days that someone in overseeing bodies had to write up guidelines for the rollout of pediatric vaccines once they received all the proper approvals. And that hasn't seemed to happen, though, because after we've sacrificed and after we've waited and after we fought for and advocated for our children, we are still fighting to protect our kids. We can pre-order books and phones, but we can't find any answers about where we'll find a vaccine. The county says to contact your pediatrician. The pediatrician says to try the county or the medical group. The medical group says they won't offer vaccines and contact the pediatrician. Some places don't know when they'll have it or how it'll be administered, nor will they confirm if they pre-ordered. But yet they will say that they'll only have the vaccine that will take an extra 7 weeks to get through the primary series. Or the parents in Florida who want to protect their kids with vaccination are stuck in a state that has refused to pre-order the vaccine, and the privileged ones are stuck driving hours to get it. I've seen countless parents continue to feel defeated by the lack of communication, and after the months we've waited, it's unacceptable. The bottom line is this: both of these vaccines met their immunobridging and safety endpoints. Therefore, if we are still recommending this vaccine for all children over 5, today we need to be recommending it for all children under 5. COVID can result in serious harm to our children, and the messaging from our governmental agencies that children are not vulnerable to these harms needs to change. We've seen the vaccine is safe. Other countries, such as Germany, have been allowing its off-label use for months, and we've seen the results of rigorous trials that thousands of children have bravely been a part of. And while we know that additional boosters will be required and that this is not the end of the road, it is our only hope at this point to taking a step towards normalcy when we live in a country that has abandoned all protective measures and left these kids behind. Thank you.
Thank you for your comments. I want to thank all of our public comment speakers today. We really do appreciate everyone who contributes to this meeting through both written and oral public comment. And with that, that is our last agenda item for today. So I would like to thank all of our speakers and our members and liaisons for the conversation today. We look forward to meeting again tomorrow for additional presentations and for votes on these 2 vaccines. Dr. Wharton, are there any further announcements?
No, we will be reconvening tomorrow morning at 10 a.m. Eastern Daylight Time.
Thank you. So today's ACIP meeting is now adjourned, and we look forward to talking to everyone tomorrow. Thank you.
Goodbye.